I'm Bob Meenan. I'm Dean of the BU School of Public Health, and I want to welcome everyone today to the 2009 William J. Bicknell Lectureship in Public Health, which is now celebrating its 10th anniversary this year. So it's good to have you all here joining us today. This session today is a part of the Boston University Alumni Weekend, which is going on now, and there'll be events all over the campus and all over both campuses. So I want to take this opportunity to plug the Medical Campus Alumni College, which is tomorrow morning here, actually over in Baxter Auditorium at 9 o'clock. The topic is healthcare reform and the promise to address health outcomes disparities. And the keynote speaker is going to be Lou Sullivan. Lou's a med school alum, was actually one of my teachers years ago, then was the Secretary of Health and Human Services and President of Morehouse College, so it'll be nice to have him back. Well, the Bicknell Lectureship was established in 1999 with a gift by Professor and Chair Emeritus Bill Bicknell of the International Health Department, and we're fortunate to have Bill here with us today, hiding over on the side there. Bill, I want to acknowledge Bill's instigation and support for this lectureship, and also that of his wife, Jane Hale, who's been a friend and supporter. Jane took a tumble and broke her leg a few weeks ago, and so couldn't join us here today, but I'm sure she's here in spirit. Bill has a long, varied, and distinguished career in public health, including serving as senior physician for the Peace Corps in Ethiopia and for the United States Public Health Service. He has served as medical director of the Health and Retirement Funds of the United Mine Workers of America, and he was Commissioner of Public Health for the Commonwealth of Massachusetts. He was also the founding chair of BU School of Public Health's Department of International Health. And those of you who have been involved with international health here realize what a remarkable story that has become over the last decade. Bill's currently involved with the government of Lesotho in designing and implementing long-term programs to mitigate the impact of HIV/AIDS. So I'd ask you to join me in thanking Bill for his support of this lectureship and for his distinguished career and contributions to public health. Bill? Well, it was Bill's idea to establish an annual lecture that would shake things up. Once again, those of you who know Bill can sort of see that thinking. And the idea was to bring important topics and thinkers to campus to stretch the minds of faculty and students. And over the past decade, the Bicknell Lectureship has certainly done that. We've heard from such people as Kurt Schmoke, the former mayor of the city of Baltimore, who spoke on the topic of drug control policy, and particularly on legalization. Tara O'Toole, who was director then of the Johns Hopkins University Center for Civilian Biodefense Strategies, came in early to talk about the topic of bioterrorism and public health preparedness. In 2003, we hosted Professor Martin Marty from the University of Chicago Divinity School, who spoke on the interesting topic of religion and public health, friends or foes. In 2005, the lectureship featured Mount Sinai School of Medicine virologist Peter Police and distinguished scholar John Barry, who together covered both the science and history on public policy for pandemic influenza. And last year's session dealt with the timely topic of human papilloma vaccine. And I was saying to one of our speakers today that I thought last year in particular fulfilled what I see as a great purpose, is having people come to a session where they're pretty sure they know what the answers are, and leaving and being less sure of what the answers are. So this year's speakers also promise a morning of stimulating ideas and discussion. The topic, as you know, is tobacco regulation and the FDA, which we have posed with the rather provocative question, is there such a thing as a safer cigarette? Before I introduce our Bicknell lecturer, I'd like to explain the program format. After the main lecture presentation, we will hear responses from our panelists. We will then take a 10-minute coffee break, which will be followed by a panel discussion and questions from the audience and exchange amongst the panelists. So I know it's risky when you take a break in a program like this, people leave, but don't. This is going to be a good second part. So please come back and participate in the panel and in the program, okay? And we'll be done by noon. So it's important to note that we're videotaping today's program, so when we get to that, and I'll remind people, when we get to the Q&A portion, make sure you use microphones so that your questions will be properly recorded. Well, it's now my pleasure to introduce the 2009 William J. Bicknell Lecturer, Greg Connolly, who is Professor of the Practice of Public Health at the Harvard School of Public Health, and also an adjunct professor of international health here at BU School of Public Health. Professor Connolly teaches and conducts research at Harvard School of Public Health on tobacco and health issues. He's published more than 100 scientific articles on tobacco product design, marketing, and tobacco control interventions. Greg is the former director of the Massachusetts Department of Public Health's Tobacco Control Program. Over the 10 years he directed the program, cigarette consumption fell 50% in Massachusetts, which was 3 times more than the national average. He was the second American to be awarded the Surgeon General's Medallion by C. Everett Koop for his leadership in passing the Federal Comprehensive Smokeless Tobacco Health Education Act. He's recognized as an international expert on smoking and health and is credited with ending the U.S. use of trade threats to compel foreign nations to import U.S. cigarettes. He's testified before Congress on more than a dozen occasions and appears regularly on U.S. national news networks. He is a graduate of Holy Cross College, Tufts Dental School, and the Harvard School of Public Health. Please join me in welcoming our 2009 Bicknell Lecturer, Professor Gregory Connolly.
Thank you very much. I feel like I am home. I have to admit that I feel somewhat uncomfortable at the other School of Public Health many, many times because I'm not close to where I grew up as a public health practitioner. When I first got out of dental school, I found myself back in 1974 and 5 over in the South Boston Health Center caring for probably one of the poorest populations in Boston, with helicopters flying over and racial hatred rampant and smoke filling the pediatric waiting area. And I was really confused. I just didn't know, what was right or wrong or how we could fix this area. But I think South Boston at the time really provided great insight into the problems in our society, the multiple problems that affect health. I had the fortune then to come and serve at just across the street at the House Officers building, helping building a healthcare system and the early neighborhood healthcare system in the city of Boston, seeing that grow, and also seeing waning health disparities, although it's still an enormous problem, seeing us deal with racial hatred, seeing us bring public health to the most vulnerable. And I'm a kid who grew up in Boston. I didn't grow up too far from this. I always tell this story. I was in the White House a few years ago, and I was talking to someone, and I said, when I was at Latin school in class 6, I had the opportunity to march in JFK's inaugural. I was a very young kid, and all the city kids were in, lousy uniforms, and all the rich kids from Wellesley came down and whatever. And but Kennedy stood up when we came by. Although my trombone froze, it was so cold that day, I'll still remember it. And everyone was changed. And I was in the White House, told a story, and I said, but then about 8 years later, I was in front of the White House again. But I was getting tear gas this time. And that was a real change, And the current president at the time said, well, I'm glad you're inside today, not outside. So I said, thank you. And then just more recently, we had the opportunity to be with the president on the signing of the FDA bill, and it was probably Orwellian to see and know this guy is signing such a piece of legislation while still being a smoker. And I still can't get that through my mind. But if anything, the bill is Ted Kennedy's bill. The night he got it through the subcommittee, when he worked so hard to get it through the Republican opposition led by R.J. Reynolds, he spent 3 days in that subcommittee. He got it through. Out of the blue, I got a phone call. Everybody in the room who is in Massachusetts has got these phone calls. I know it. And it was from the senator. I couldn't get him off the phone. He said, Greg, thanks for all the help. And I said, Senator, I didn't do anything. You're the guy that got this thing done. And if anything, this bill will go down, I think, as a testament to the senator trying to fix issues that we had in Massachusetts at a federal level, and at the same time trying to fix issues that other states couldn't address. I'm so pleased to be here at the Bicknell Lecture. Bill was commissioner before I came, but we joined together. I was working on the fluoridation bill, and I remember being with the governor and Bill being present. I came in after the second commissioner, but did spend 25 years in the health department. And Bill's legacy lived on through all 25 of those years. I'm not sure if I'm going to answer your question this morning, but I'm going to talk about a framework that will allow us to answer questions, and just not whether a cigarette is safe or not, but whether maybe a society can be safe from tobacco if we apply this legislation correctly. And if we don't apply it correctly, we probably could wind up with, in quotes, a safer cigarette, but a society that suffers still from an enormous burden of disease. Okay, is there such a thing as a safe cigarette? And I think we'll try to get to that question, but maybe more talk process in getting to that question. But let me just first off state that, cigarette smoking is a leading cause of preventable death and disease in America. We're still experiencing, despite declines, around a prevalence rate of 22% of Americans, daily and occasional, and we're claiming about 400,000 lives per year. The first finding was in '64 with the first Surgeon General's report. And when countries make major public health findings, they generally act on them. What our Congress did immediately and over the next few years with every major health and safety bill passed by the Johnson and subsequent administrations was to exempt tobacco products. Controlled Substances Act, Toxic Substances Act, Federal Substances Act, Hazardous Substances Act. The only act that was passed in 1906, amended in 1936, was the Food and Drug Act. And so when Kessler tried to assert authority, he lost before the Supreme Court in a vote of 5-4, saying, basically, in the eyes of the federal government, tobacco products, not their marketing, taxation, or advertising, but the product is an outlaw. It exists outside the law. We in Massachusetts attempted to require ingredient disclosure, thinking perhaps maybe the states can fix this issue, and wound up in federal court 6 years, losing before the Supreme Court by the same 5-4 jurist who said the states lack authority and it's unconstitutional. We were as a state back in 1998 attempted to ban advertising near schools and playgrounds, and again wound up before the previous case was appellate courts. This was at the Supreme Court, Lorillard versus Riley, and we lost on that matter. The states lacked authority to restrict advertising of tobacco products near schools and playgrounds because of commercial speech issues. This is what I say to Kennedy. Kennedy did come in and try to say to us, well, we can help resolve state issues, but at the same time fix federal issues. But we're looking, and people can debate this, but we are looking at an outlaw. We have no national policy on tobacco. We may tax it. We may put on something we call a warning, but it is not a warning. No one can see it. We may inspect it, but by and large, our success on tobacco has been state and community efforts. But is that sufficient? As a state public health official for 25 years, I think I can speak to experience, and that is we lack either the jurisdiction, where we wind up having our head handed to us in federal court after the tobacco industry expends $20+ million to defeat us, and the Attorney General's budget is a pittance of that, or we lack the scientific expertise to do very thorough investigations of questions like, is this tobacco product safer than that tobacco product? What we require in this country to deal with this epidemic that ravages people around this community, not so much in communities that I now live in, is a comprehensive policy that balances local, state, and federal interests so we, like any other developed country in the world, can address public health enemy number one. What does the bill do? I try to break it down into nutshells, and I'm not sure if my FDAers would agree with me with this or members of Congress, but one, I think it does a pretty good job of taking what we've already done at the state level and nationalizing it. We now have a uniform fee that's increasing price. There's reference to FDA speaking about tax increases. We're going to have uniform access programs across the country to prevent kids from buying cigarettes, potentially a mass media campaign. We're going to enhance our treatment activities through FDA. And we're going to finally get a chance to put some warning labels on there that are probably better than we see in Poland or Thailand. The second area, and it's probably an area that is embraced more by the tobacco industry than groups that I know of, And that is, no, I'm sorry, the third area, that is to try to reduce the product's toxic characteristics. And we've seen an intense activity on behalf of the tobacco industry, probably more for garnering market share from one company to the other, to somehow come up with what's called a potentially reduced exposure tobacco product. And I think we have to establish very careful scientific standards so that we don't protect the tobacco industry in this area, but we protect the public health. And caution oftentimes in public health is the rule of thumb. But the second area is to reduce use. The FDA bill, its value is to reduce the current decline in tobacco use so it's going down quicker than it currently is. And to use product regulation combined with the interventions we now have available federally to do so. And how do we do that? It's probably looking at those very factors that the industry has taken, and taken a fairly crude nicotine delivery device in 1917 called the Camel cigarette, and turned it into one of the most sophisticated, highly effective nicotine delivery devices known to man through the use of 500 plus additives, extremely sophisticated design features, and then combining that with nicotine dependence so we create what we have today is called Marlboro. Well, we think about mechanisms to think like the industry and potentially reverse engineer enhanced addiction or addiction so that we finally are on a level playing field with the tobacco industry when it comes up to regulation of the product. We don't allow oxycodone manufacturers to add pH modifiers, sweeteners, menthol, or other ingredients so they enhance use in the street, nor should we be thinking and allowing that to occur with tobacco products. So our three scenarios. If FDA pursues only a reduced harm strategy, just focusing on making safer cigarettes, because somehow we think there's someone out there that can't quit and they need a safer product and we have a moral obligation. And by the way, the only person that I kind of think who really meets that category may be sitting in the White House, I'm not sure. But if we do that and we stop our decline in use, this is our current decline. If we don't do anything, we're doing pretty darn good. If we can insert safer products and arrest that decline, then we haven't made a success. If we can combine all three and accelerate the decline, then I think we're going to be looking at potentially a tobacco-free society. The industry for safer cigarettes, not the industry, but the FDA is using a term modified risk, in quotes, tobacco product. And what do they classify in that? Light cigarettes, which have been around since the first Surgeon General's report. Novel devices. These are devices that generally heat tobacco. They don't burn it. They're called Premier, Eclipse, Accord, e-cigarettes. Modified cigarettes, which reduce smoke constituents but still burn. Low tobacco-specific nitrosamines, modeled after a Swedish product. And then, regretfully, the bill exempts substantially equivalent products as modified risk products. If something like it were on the market 2015-07, that's probably there because of one of the tobacco industry's heavy exertion and lobbying. But it means for the conventional tobacco products, we're going to have difficulty getting them encompassed as a modified risk product so that we can put it through exhaustive regulatory strategies. The other products, we will be able to do so as modified products. We have problems regulating products. And I'll go through the problems and I'll go through where we're at, what's in the marketplace. One, just trying to determine how do people smoke, and after they smoke, what gets in their body. Ultimately, how you smoke and the type of cigarette is going to determine your exposure, but you're going to have to measure the exposure of toxins, relate those toxins to biomarkers of harm to understand if and when you can reduce a toxin in a product that will in turn affect the exposure in the body and in turn affect a biomarker of harm. Our problem is the measures to do that are very weak. We have controlled trials with smokers that often create experimental or artificial conditions that don't allow accurate assessment. FDA's role may not be so much to encourage development of safer cigarettes, but assure what's out there, currently light cigarettes, which from the NCI investigations have found to offer no health benefit and to be deceiving to the public, and to what's called PrEPs, or the products I mentioned earlier, to meet rigorous, relevant scientific standards before the public is exposed to either the product or their marketing claims. So caution, based on the framework established by the FDA, may be the better option than willy-nilly allowing products to be put in marketplace while we're already seeing a 2% decline in consumption in America, and we have yet to see a cohort on a population basis who our current interventions can't reduce use of tobacco products with. And even looking at the statements by the FDA and the Federal Register, they clearly state, this appeared in the August Register, July Register, FDA is primarily interested in reducing incidence and prevalence in protecting the public health. Okay, what do we have? This is a modified cigarette. It's Omni. It reduces the gas phase carcinogens partially. It says it makes no health claims. Reduce carcinogens. I have my commercial right to make that statement. The consumer can choose. This one has fewer levels of toluene and acrylamide. When we tested this product among consumers, they perceived the statement, reduce carcinogens, as a direct, explicit statement for reduced cancer risk. In the eyes of the bill, in the eyes of the law, that claim then becomes a claim for reduced harm, just not reduced exposure. We have Quest cigarettes. It's another modified cigarettes. This time, the tar stays the same, yet the nicotine comes down. We have Accord. Now we get into our novel devices. And these are all in the marketplace, or have been in the marketplace. So I'm not saying, FDA is going to encourage this. This is already here. And we have no state authority to deal with these products. We lack the expertise. We lack the regulatory authority. We need authority to begin looking at these claims to see if they're false and deceptive, to see if these products, in fact, help or hurt, to see if they contribute to population harm, such as more kids smoking, fewer kids quitting, or former smokers coming back in. Accord is a battery-packed heated cigarette. You plug it in. It doses you 9 doses of nicotine. The carcinogens are fairly low. You get a good full dose of nicotine. We have Eclipse. Eclipse is more like my miniaturized version of my outdoor Weber grill. It has a charcoal element in the front that ignites. This is the former. It's his premier, actually. It's the granddaddy of Eclipse, or the father of Eclipse. Produces carbon monoxide. It goes through a bed of reconstituted tobacco sheet, releases glycerin with nicotine, injected into the body, and you get a blood nicotine dose of nicotine equivalent to that of a conventional product. I would point out there's nothing in this product that's natural. Nothing came off a farm. Nothing. Eclipse made a claim, this was interesting, back about 10 years ago, that there is no, if you see it up top there, there's no cigarette like Eclipse. This is unique. And implied in that claim was, this must be a safer cigarette. They also made claims, this may reduce lung cancer, this reduces your exposure to secondhand smoke. Well, what did they do? They compared Eclipse to Marlboro Ultralight. So, of course, me and my wisdom with my close friend John Slade, who's no longer with us, we went out and we bought a carton of Carlton and Nows. They're on the shelf, right? And we compared emissions based on the Mass Department of Public Health testing system to see if there were cigarettes on the marketplace that yielded toxic carcinogens similar to Eclipse. And in fact, we found in Eclipse we had higher levels of NNK, a very, very potent carcinogen, higher than what was found in cigarettes in the marketplace. So one had to raise questions, was that claim an accurate claim? But it was made. If a state tried to restrict it, the state would most likely spend a long time in court through the Attorney General's authority trying to stop the claim. We also found elevated levels of benzopyrene, so on and so forth. The interesting history of Merit cigarettes. It was a cigarette that Philip Morris brought out in the 70s. The first Merit cigarette was very low in toxins and in tar yield, but it didn't sell. So Merit, come the mid-'80s, Philip Morris then creates basically a cigarette that's much similar to a Marlboro Light to increase sales, but doesn't tell the consumer anything about what they did to the product to institute that change to increase market share. This industry is driven solely by making profit, not health. And do you think that an industry whose prudent man rule drives what their decision making is, how much profit do they return to investors, can put health in front of it, is not a valid assumption. We're dealing with a business whose responsibility is to their shareholders to return profit. Generally in America, we establish regulatory agencies at the federal level to try and make sure, we don't do a good job for sure, that that business is not allowed to harm, deceive, or hurt the public health. Right now, we have an industry, as I said earlier, that stands outside the law when it comes to the product, without any federal oversight agency, and the smokers, particularly those who are disadvantaged, are at the mercy of what the industry wishes to do to enhance product sales. And it's time that we had an agency that could protect us. This is Eclipse. Again, we compared Premier Eclipse. This is the same cigarette looking at nitrosamine yields under a standard smoking condition over a period of time. And what we saw for two very potent carcinogens, NN and NNK, they're tobacco-specific nitrosamines, NNK linked with adenocarcinomas in the lung, that in 98 we're down at this level, 96 at this level, and all of a sudden 2000 it jumps to this level. And no one told anyone. We figured out, well, why did that happen? Well, in our wisdom, we bought a couple of packs and we looked, and they drilled a hole in the bottom of the filter. They call it a hollowed filter, which I still can't figure out what that really means. It's a hollowed filter. Well, I guess for the tobacco industry, toxins make it taste better. So if you want to sell it, just put the toxins back in, but don't tell anyone. And continue to make your claims. More recently, Marlboro Ultra Smooth, Philip Morris brought this into 3 test markets. They varied the amount of carbon-activated charcoal, Atlanta low level, Salt Lake a high level, and they made claims. And they reported yields based on the tar levels based on what's called the FTC testing method. The FTC was established, a method established in the 60s based on how people smoked in the 60s. We did is we took the product and we tested it on how people smoke today. We used the Canadian condition, the Massachusetts condition. Canadian is probably more extreme, it gives the outlier. And we saw, did that change in how people smoked? Did that affect the yield in the smoke? And in fact, we found that it did. That we found what was initially being claimed or being portrayed, there was no direct claims by PM, I'll be fair to them, as a reduction in gas phase carcinogen under a very nominal condition. When you smoke the cigarette at a more normal condition, because of the burn intensity, the draw, other factors, your percent decline fell sharply, which would indicate your exposure would also drop. So again, the state shouldn't be doing this, or a university shouldn't be doing this. This should be tested before it goes in the marketplace by a scientific agency that has both the resources, the credibility, and the understanding to do so, so we don't see products drop in the marketplace portraying themselves, either implicitly or explicitly, as reducing risk. Smokeless tobacco. The industry is pushing, they've acquired, it's interesting, over the past 4 or 5 years, the U.S. cigarette industry has basically bought out the U.S. smokeless industry, which was an industry separate from the cigarette industry, in which, you could see in competition in the marketplace that may be a good thing. They may be promoting, at least on an individual basis, a product that could reduce harm. Now all of a sudden we see Camel Snus, Marlboro Snuff. We see joint names of products for both a cigarette and a smokeless tobacco product, now owned by companies whose primary interest is selling cigarettes. Smokeless tobacco was sort of conditioned on the Swedes have developed health standards where we can reduce the toxins. We know they're lower than what's in the US. And we'll talk about that in a second. So we got a standard out there. Then number two, there's a continuum of risk. That if you look at the risk of cigarettes versus smokeless versus nicotine gum or quitting, it's pretty much a linear continuum. I wonder if those are true. But again, these are assumptions. These are assumptions, they're not decisions made by scientific agencies. Well, first off, in Sweden, the claim was that smokeless tobacco resulted in a decline in tobacco use in Sweden among males. If you look at daily and occasional Swedish smokers, it's not true. There's been no change in Sweden among daily and occasional. If you focus on daily, yes. This is the use of current smoking, daily and occasional in Sweden. This is daily snuff users, and these are smokers. And the snuff, the point important to note is your snuff use was already going up in Sweden prior to the decline in smoking. And somehow it's been portrayed by industry as being a direct relationship. The direct relationship doesn't occur. And now we see an increase among women. And if we just go next door to Norway, a like population, although I don't know any Swede or Norwegian would say that they're like. I think they're as different can be. Among boys, 18 to 16 through 17-year-old, in 85, daily snuff use was 9%. It jumped to 33 by 2004. Prevalence of daily smoking didn't change, or if it did, it was marginal. At least in Sweden, among the younger male cohort, all we saw was continued smoking by young males with the adoption of snus. Then if you look at the recommended levels by the Swedish tobacco company, which is implicitly portrayed as being safer levels than what's in US products, and compare them to levels that we would look at in food or beer or bacon or baby bottle nipples or in air in California as established by either EPA or FDA, we don't have levels that are all that low. This is our cancer-causing agents. We're looking at 10,000 nanograms per gram. What does recommended by EPA on an exposure basis? About 10. So we're looking at a level about 1,000 times greater than we'd accept in air in California. So even though the levels have come down 50%, 50% from what? Is it jumping from the 25th floor versus the 50th floor now? We look at heavy metals, and that's a major concern in smokeless tobacco. Heavy metals, many are carcinogenic. They have systemic effects, which we have yet to identify with epidemiology. Yet, Swedish Match, which is being now referred to as a, in quotes, health standard, really came up with a manufacturing standard. And I think for all of us in public health, we must be vigilant not to allow manufacturing standards, which are really based on technical ability to, say, take out a toxin, to be viewed as a health standard. Health standards are based not on technical feasibility, but the impact on the population. And again, the heavy metals are probably 20 or 30 times greater than we would allow in other food products or other consumer goods. So the concept that the industry has a standard for smokeless tobacco is not necessarily true. And I think we have to carefully look at before we as a society begin to condone these products what they mean. There's also a population effect. We've done a great job reducing tobacco use among people who wear ties in America and people who dress so lovely as Cheryl Healton. And she quit. But this product is being positioned through marketing as a supplement to smoking. When you can't smoke, use this, use Exalt. Picture yourself on the back of a bike. You can't light up. Use this product. Arriva, anywhere, anytime. And all one has to look at the fingernail to know who they're targeting. People who don't currently use the product. This is not for, converting adult male smokers to using these products. Or I picked up Playboy in December. It was a 12-page spread. I If you go to YouTube, you'll see all the Playboy bunnies doing their skull shoot with all the 15 and 16-year-old males who go onto Facebook and YouTube and who just salivate while they're dipping over the beauty of these smokeless tobacco products. What we're seeing in the companies, R.J. Reynolds calls this an expansion of choices, not an alternative. When Philip Morris brought in Marlboro, snus, and snuff to Dallas, I said, great, now I know you're going to stop selling Marlboros in Dallas, and they laughed at me. Any reasonable, responsible industry wouldn't laugh. They would say, yes, we're going to stop selling Marlboros. We do admit it causes harm. We know it's addictive. We now have something that, if we can get all of the individuals to use it, we're going to reduce risk. But in reality, they see this as a complement to address that slide I showed you earlier, where they're experiencing a 2% decline in tobacco consumption. What better way to arrest that decline than to have a product that potentially undermines the effects of a smoke-free environment like this, or is taxed so low at the federal level that it's relatively cheap, a source of nicotine delivery. And what is the best experience? It's the United States. This is back when the blue line is males 18 through 24, purple line is adult males 45 through 64. This is snuff dipping. This is when the United States Tobacco Company introduced what was called the graduation strategy. They introduced low nicotine skull bandits with the intent of allowing new young users to move up to brands with higher nicotine over time as they became dependent and tolerance came in. This was tied in with a college marketing campaign. They had 200 college reps on colleges throughout the United States of America. They also advertised with sport figures like Carlton Fisk and others on television. They gave free samples to baseball players, which then became a fad among the baseball players and still is, unfortunately. And what did they do? They made a ton of money, recently taken over by Philip Morris for $13.6 billion last year. And use rates among this age group soared. This is a population problem. I'm not looking at an individual here who's 45 and used snuff and all of a sudden he was smoking Marlboros and switched to snuff only and quit. I'm looking at a population of people. And as public health officials, as public health students, as public health academics, populations are what we must think of when we work with policymakers. And everyone says, well, no one uses Nicorette, so we need to give them something that's like the cigarette, like snus, or like the modified cigarette. These are sales for Camel snus and tobacco. They're not selling. These things are so radically different in terms of nicotine delivery and appeal, they're not gaining market share. Yet, when we compare it to Nicorette, or whatever, the point is Nicorette is outselling these products. And for people to say Nicorette is not selling is a misnomer. If you look at Nielsen data, Nicorette is doing quite well. People are using it. People are quitting. We don't need to bring in a whole plethora of new products necessarily that we don't know that are safe to move in that area. And this is from Philip Morris. This is from the industry, where they're looking at the introduction of smokeless. The majority of our survey respondents do not believe either of the new snus products will affect smoking volumes, cigarette volumes. It's a good thing. Rather, new snus will most likely attract smokers that have previously quit, that are currently using snuff, and smokers looking for a temporary nicotine kick. Let me just switch the line a bit here. The bill also bans the use of terms light and ultralight. These have been on the market for about 4 years, 6 years now, and you won't find any light or ultralight in these products. What you find is colors: blue, gold, silver. So the industry, you know, and in their internal documents, they clearly state light does not mean safe. It refers to taste. Lights will help you quit. That's their public statement. If you look at the internal statement, light and implied healthy safety claims, there was little doubt that the package design with its relevance upon the central gold panel against a white background projected the impression of a very mild cigarette. What the industry says publicly about light cigarettes and their opposition to the ban on lights, which is contained in the bill, they have entirely different statements when you look at the internal documents. What the law says is after 2007, after June 27th of next year, lights are banned from the marketplace, unless they come in and are approved as a modified risk product under science, which I think is fair. No one is restricting their constitutional speech to make a claim, but we're just trying to make sure those claims are made in the context with science. What does the bill also say? Well, the bill references when we set standards, we look at the population impact. As I showed you earlier, if you bring in snus and your population research shows the only people use it are non-using teenage males who play sports because they want to look like a baseball player, then maybe that does not have a population benefit. If the only people that use it are a heavy adult male smoker who quits completely, uses it, and then quits, it does have a population basis. But as a society, we need science to make those decisions. We just don't gamble with people's lives and health based on what's in the interest of the tobacco industry. I think you can't. That's okay. We'll skip over this and save you time. We stuck there? This slide is not coming through. What I basically wanted to show on this slide is here you have a person smoking a cigarette with a behavior, then they're exposed to toxins within their body. Right now, this is as far as we measure. We do not measure on a routine basis exposure. And until we know an exposure, we're going to have a really hard time making any type of relative judgment just on exposure. Does this product reduce toxins or not? And that's on exposure claim only. We go further. In exposure, you may reduce exposure 50%, but is it going from the 90th floor versus the 110th floor? What we really need is biomarkers of harm. Such biomarkers include NNAL as one. The number of biomarkers we have that are validated, that can be replicated, are minimal at best. NNAL, yes. So at least for combusted products, before we move down that route, there's a lot more science that has to be created to make sure that we can say to a consumer, yes, in fact, of 8 important biomarkers, when we validated, we saw that your risk fell 80% from harm. So we do a basic risk assessment, as would be done by FDA, EPA, or other agencies. Then we take our risk assessments and before a body of expert scientists weigh those risks. What are we going to weigh those against? What is the population effect? Do we run the risk of bringing in back smokers who quit? Do we run the risk of kids going on, starting with this, quote, they think safer, and then switching to other products? This is a complex problem, and I, at this point, can't answer the question. What I can say confidently is this nation has finally passed a law, the first nation in the world that has set up a protocol, an organized system, with guidance from Congress to answer the question. What I can say with confidence is that in public health, we practice caution because it's people's health that we're dealing with and that we have assumed responsibility for. This law has changed the whole dynamics. Whether the industry agrees or not, it's moved, in a sense, responsibility more from an industry who in the past has totally rejected any responsibility for their product and now placed it in part in the hands of the FDA. And anyone who serves in FDA then, out of caution, should make decisions, not those that Philip Morris would make, on what is the profit margin for the next quarter, but what is in the best interest of the public health today and 30 years from now. I'm going to move on here. Let's just talk about warnings a bit, and I'll wrap up on that. And I know it's part of the discussion. Again, we have a structure and a system to deal with the question of safer cigarettes. It's not going to happen overnight. We are going to set up a system to prevent claims, implied or explicit, for the plethora of products that are out there in the marketplace today, so that at least we protect consumers from what's occurring. But on the other hand, we can finally do warning labels. This is something that virtually every major industrial country in the world has done. We currently have no warning labels, even though some people may argue they can see some specs on the side of their pack. Whenever we bring warning labels in, the industry is opposed it. I generally call it the smell test. If the industry's opposed it, then maybe it has some value. Industry in the past has supported text-based warning using black and white, high cognitive but questionable effective value. They've opposed graphic and pictorial warnings. They've evaded the ban of light descriptors where they've come in. And in a sense, they attempt to control and set the debate on what should be on the pack. Just for the sake of time, move on. This just came into the marketplace a few months ago, where Salem, which was being sold as Salem lights, now are being called gold. Or Salem green is now a silver box. This is a year before the FDA bill. Pall Mall lights now, when you go out to buy them, they're called Pall Mall blue. Pall Mall ultralights are now called Pall Mall orange. It's funny, I went into the store the other day. Hey, give me a pack of Pall Mall lights. We don't have them. What? No, we don't have them anymore. Here, take these, the blues. They're the same. No, I want the lights. I only smoke lights. I don't smoke blues. No, they're the same. The company told me they're the same. They gave me a sheet. So the first thing that happens when government goes in and intervenes and tries to establish some reasonable standards for protecting people against the false and misleading use of the term lights, the industry goes around and evades it with colors, basically trying to bring us into a debate of what's worse, dark blue, light blue, medium blue. And God help you if you go to court and the federal justice is wearing a blue skirt. You're lost. You're dead. Here's Misty, More, Advantage. We see the same procedure occurring. It's only going to get worse. And then we see a direct correlation between color and between cigarette strength. This is the most interesting thing. Ventilation is the trick the industry uses to dilute the smoke so that when you smoke, before it gets in the machine, air gets into the flue of tobacco and you get a low machine rating. 52% of people either occlude the holes, smoke more deeply, smoke more intensely, or smoke more cigarettes per day. Ventilation cigarettes, according to the National Cancer Institute report, have done nothing but deceive the American public. And we see a direct correlation here between red, low ventilation, gold, moderate ventilation, silver, which is the light, high ventilation. And the same true is of Camel. Maybe we should be thinking about regulating ventilation, sugar, menthol, organic acids, or those other constituents that create a deception of safety when none occurs. Maybe. And I don't know the answer to that. A warning label campaign, if we did, I think different countries have used different approaches. And my suggestion is, if you go to Brazil now, on the back of the pack, you have highly graphic negative images. I don't think that's appropriate myself. I think you have to make your pack empathetic, maybe a warning on the front. Then in the back, bring in a very strong graphic image. You can do corrective messaging. Australia does that. They have quit line numbers on the back. They have links to other websites. They provide more information. But more importantly, I think a good, strong national warning label campaign can become a focal point for a national campaign that involves the states, that has national advertising. and such. Research that we have done in the Massachusetts campaign showed that testimonials of individuals who smoked with graphic imagery proved much, much more effective after we waited for how many ads we bought than ads that were done by pharmacy companies, inspirational quit ads, or others. This is the series of ads we termed illness. Rick, you've probably seen him on TV, Pam, Ronaldo, Debbie, Cowboy. And interestingly, when we, on the Mass Tobacco Survey, which is a longitudinal cohort survey of adults observed in 3 waves, those that reported exposure to television ads were the highest of quitting aids. Now, everyone sees a TV ad. Those that quit from seeing a TV ad was relatively modest, about a third seeing a TV ad. And this is an intermediary data. This is not directly causal, but it's good suggestive data. But because the reach was so high, the impact turned out to be greater than professional self-help or others. So warnings themselves can have an impact. This would be the ideal warning campaign in my mind.
I think about getting a call for next transplant. You know, I'm kind of afraid that I would get up and say goodbye and wait for the last time.
So we'd put Pam on TV. Then maybe on a cigarette pack sold in Massachusetts, we have a picture of Pam. Empathetic, it could be me. It's not startling, it's not glaring, it's not skull and crossbones. Maybe look at manipulating the color. This should be a red Marlboro light. Let's put in smoking kills you smoothly. By doing so, we laugh, but smoking for the long-term smoker is basically an emotive process. It's a series of emotional cues that build on nicotine addiction. Visualization of the red, tasting of the Marlboro flavor, impact from the free nicotine. All of those build and build and build. And they go to a body in the brain called the insula, which affects emotions, which then create an anticipatory sense of reward. And what do you got? You get tobacco dependence. And it's brand specific. One group will smoke Marlboro Light 100s, other group will smoke cool, high nicotine. You won't get them to change. Well, if we can break that chain through messaging, we can let cognition kick in. So if we go in and alter the color, maybe someone takes a step back and says, now I can think. And we know that theory is true in other areas. The back of the pack, we can use that as a way to provide information about quit lines, call-in sites, more information. Then even a point of purchase. FDA has the authority to require point of purchase ads. So we build synergy with the national campaign. We use the same tools that the industry has through regulatory and program authority to develop a campaign strategy. This is taken not too far from here. We did this as part of Operation Storefront when I was at the Department of Public Health. And we measured cigarette advertising near schools and playgrounds in Boston and other communities in Massachusetts. We then passed an Attorney General regulation. We were sued that afternoon by, I think it was 8 tobacco companies, 9, 10, I forget now. And we lost before the Supreme Court. It was really a fun experience. The kids from Boston, Rainbow Group, we took down to the Supreme Court and managed to get in. And the way I got them in is I went and I saw Clarence Thomas and I said, Greg Connolly, you're a resident of Holy Cross. Greg, come on in. And so I couldn't tell him I was there. And so we were in there, and Clarence never asked the question. This time he says, well, next to our Attorney General, you're going to ban McDonald's because it makes kids fat. He thought I was a tobacco lawyer. See, if you go to Holy Cross, you either become working for the tobacco industry, or you're a Jesuit, or you maybe do something good with your life. We just recently went around Roxbury and Dorchester to see if anybody had changed. Because we were sued, we lost. The ads were still up there. And here we have still an extremely high concentration. The blue is all around a playground at Dorchester. We went to Brookline, we couldn't find anything. Well, guess what? Kennedy managed to get in the bill a ban of advertising of cigarettes within 2,000 feet of a school or playground. And I figured, hey, it's great. This industry says they don't want to see kids smoke. I mean, so they're going to support us. Lawsuit filed by R.J. Reynolds and Laura Lard against that ban as a restriction on commercial speech, because they have something to tell their consumer. I've yet to see anything in a cigarette pack with any meaning to a consumer except deceptive messages such as lights or ultralights. I would love to see something in a cigarette pack that really had some meaning to a person. We've banned candy-like flavors. Unfortunately, menthol was not part of that, but we can still restrict menthol. I've got to probably not take too much time. This gets, just in winding up, this gets to my point is that kids smoke cigarette brands. This is the variation between Camel, Marlboro, and Newport in kids' smoking rates. It's about 80% of kids will smoke these brands. Adults, it's going to be lower than 50%. So the industry will design and target brands for young people that we have to be cognizant of. That when we do regulation strategies, we not only have to look at, is that product overall less toxic? These both products are probably equally toxic when push comes to shove. Their nicotine delivery is probably equal, but the color, the pack, the variation, the attractiveness, the way it creates dependence is enormous variation here. And if FDA is going to be effective, they've probably got to take a very hard look at how this variation, the package variation and the cigarette variation that work together, contribute towards dependence. Just making this pack 10% safer than this pack, I'm not sure. I'm really not sure if that's going to be what we want for America. But how do we do that? I think we go beyond just candy flavors. We look at issues such as menthol. We look at issues that enhance nicotine delivery. We look at nicotine. That's where the strength of the bill is. We make this bill a synergistic bill, so it becomes America's bill. So when we go after and we look at Cools, we're thinking about the African-American child in Chicago. We look at Virginia Super Slims. We're thinking about the young girl who's Hispanic in New Mexico. When we go after Camel number 9s, we're thinking about that kid at risk in Florida. This is not a beltway bill of scientists making decisions about is this safer or not safer for some mythical person. This bill is about America. That's what Ted Kennedy had in mind. It's not about giving Philip Morris more market share than R.J. Reynolds, although that's what the tobacco industry would like to see happen. It's about us joining together with the federal government, doing what we do well at the state level to make sure we make smoking history in this country. Thank you very much.
Thank you, Greg. We'll now move to a series of comments from 3 panelists. And actually, if the AV guy could help me just switch back to the label slide, I'd appreciate it. Our first panelist is Cheryl Hilton. Cheryl is the founding president and CEO of the American Legacy Foundation, a nonprofit whose mission is to prevent young people from starting smoking and to help smokers quit. Under her leadership, the Legacy Foundation has undertaken numerous public education campaigns, conducted research projects, and provided technical assistance and a broad program of grant making. She is the recipient of the Secretary of HHS Award for Innovations in Public Health, the Social Justice Award from the state of Hawaii, and the American Lung Association's Life and Breath Award in 2003. Most recently, she was named a Donald A. Bereth Lecturer by the National Public Health Information Coalition and is the recipient of the Troy R. Westmeyer Distinguished Alumna Award from New York University in 2008. She holds a doctorate from Columbia University School of Public Health and a master's degree in public administration at NYU Health Policy and Planning. She joined the Legacy Foundation from Columbia University's Mailman School of Public Health in New York, where she served as chair of the Division of Socio-Medical Sciences and as Associate Dean for Program Development. Cheryl?
Good morning, everyone, and thank you, Bob, for the kind introduction, and Greg for such a wonderful talk. I'm going to be very brief, and if someone can give me a 5-minute warning, because I have 10 minutes and I don't want to exceed it. Let me just preface my remarks by saying that the American Legacy Foundation has labored under certain restrictions that were written into its creation in the context of something called the Master Settlement Agreement, which many of you may know was the result of 46 states' attorneys general's negotiations with the tobacco industry and led to a multi-billion-dollar flow of money to the states. Those monies had no restrictions whatsoever on how they could be spent, which can only be described as a fundamental flaw in terms of the Master Settlement Agreement. But one of the other elements was that the American Legacy Foundation couldn't do certain things. One of the things we couldn't do was vilify the tobacco industry. So promptly in 2001, we were in litigation with them about our public education campaign. And the results of that were, after 5.5 years of litigation, that we won unanimously in the Delaware Supreme Court and were able to continue our very hard-hitting public education campaigns. The second restriction is that we cannot lobby. And as a result, I stand here before you as a public health professional who's worked in the field for 30 years and who was not able to comment on the FDA bill during the entire time that it was being debated. And that's been really pretty much since I became the CEO of the American Legacy Foundation. I had a personal opinion. I did not express it publicly because, unfortunately, that too would have been linked back to my position. I was happy to be with Greg at the signing of the FDA bill in the Rose Garden and happy to hear President Obama's remarks there. The fact is that if tobacco were invented tomorrow, it would never, ever come to market. And that bears repeating. There is no question that if tobacco didn't exist today and it was invented tomorrow, it would never be a legal product in the United States of America or anywhere else in the world. The fact that the product remains on the market, despite the fact that it kills 30+% of its lifelong users, is odd. And I would submit to you, it's no more odd that we decided to regulate it under FDA. The absurdity on some level of the situation is not lost on me, and it shouldn't be lost on anyone in this room. Now that it is law, I strongly encourage our colleagues in the public health community to look forward and not backward, with the exception of the medical historians who will write many, many books on the FDA regulation. I read one on my way here, written by a gentleman who's about to speak. There is no question that there's a story to tell about FDA regulation. The story is half written now, and it will be written further as we move forward. And the question is, as it's written further as we move forward, will it be a public health victory or will it be a public health sham? And I would say that all of us here on the panel and all of you in the room, as those of you who are in public health, and I assume most of you are, will share in that responsibility going forward. We need to look at the future, and we need to devote our considerable energies and skills to make sure that FDA authority is effective in the fight to lead to reduction in preventable death in this country. And as you know, it is the leading cause of preventable death in the U.S. and soon to be the leading cause of preventable death globally. We can lament what is not in the bill. There are a lot of things that ought to be in this bill that are not in the bill. And I would just remind all of you, since we have this front row seat for health reform, in my 30+ years in public health, I have never seen the perfect bill pass, let alone the perfect public health bill. I'm personally a strong advocate for a public option in health reform. In fact, I'm a single payer person. That's not my official position from Legacy, that's my personal position. I think it is exceedingly unlikely that we will have a public option in this bill. And the question is, should we forego the bill altogether because it is imperfect? And unfortunately, given my gray hairs, which are skillfully covered up, a trip to the hairdresser when I can squeeze it in, I think we have to just bear in mind that the perfect bill does not exist, and we have to try to make lemonade out of lemons. The absence of regulation since the inception of tobacco in this country as a major health threat has allowed the tobacco industry to perpetrate a 50+ year fraud, a fraud that was summarized eloquently by Judge Kessler in the federal litigation of the Justice Department against the tobacco industry. And the fact that they were able to perpetrate this fraud and have now been accused of violating RICO, that is, they are racketeers, in the conclusions of both the federal court and the appellate court, is something that should not be tolerable in a civilized society. So let me move to the essential theme here, harm reduction. And I'm going to talk about a couple of areas to begin with that people don't usually think of in the harm reduction box, but I think they warrant discussion, and I think they warrant very early action by the FDA. I'm a great proponent of harm reduction. I've been in public health for many, many years. There is no question that harm reduction improves the health of Americans, whether you're talking about seat belts, condom use, birth control to prevent unwanted pregnancies or the like. We do, however, have a somewhat unusual circumstance here because we have a proactive, incredibly wealthy industry on the other side trying to use any concept of harm reduction to their economic advantage. And that creates a somewhat different alchemy than we have with some other public health harm reduction issues. And I would also just say that my own experience in harm reduction has proven to me that you cannot always assume what you think is intuitively correct will be intuitively correct. And I will give you the best example I've experienced in my career, and that is I was one of a number of advocates in New York State for the creation of something called the hierarchical method of HIV prevention. I felt it was extremely important for women. It went like this. You should use a male condom. If you can't use a male condom, use the female condom. If you can't use the female condom, use a diaphragm or spermicide. And if you can't use those three, use spermicide alone. There was a huge body of evidence that diaphragm with spermicide and spermicide alone interdicted every STD under the sun, but there was no data on HIV. We operated on the assumption that you could extrapolate to that. And what happened when a large-scale trial was undertaken in Africa, a dubious trial in many respects, in hindsight, I was not personally involved in it, the discovery was made that spermicide increases the probability of HIV infection. And so I've learned the hard way that caution makes a great deal of sense, and that something that seems intuitively logical may in fact in real life practice turn out to be wrong. So I want to first talk about menthol, and I gave a keynote just a couple of days ago on the menthol topic, and I urged, as we haven't done in writing already to the FDA, that menthol be eliminated from cigarettes. I see no research agenda here that needs to be pursued any further for the following three reasons. We know from industry documents that menthol was presented to young people in marketing specifically to draw them in. The internal documents of virtually every major company that had a menthol brand has very specific internal statements about how critical to their brand it is to capture young people and how important menthol is to make it easier for young people to start cigarette use. And in fact, presently, of all teens that are smoking, 44% report using a menthol brand, which is substantially above the menthol use rates for adults. Part of that's a demographic effect, but much of it is more substantive than pure demographics. Among middle schoolers, this data was just presented by the CDC at the meeting I just attended, 77% report using menthol. So we know that menthol is a starter entry opportunity for young people. We also know that menthol cigarettes, going back to the very earliest introduction, a cigarette called Spuds, where the ad campaign began in the 1930s, was making health claims about menthol. And indeed, one company said that menthol cigarettes' main market would be as a medicinal, health-enhancing product. And if you look at all of the menthol advertising that has happened, I'm going to set aside for the moments lights and low tar, what you will see is that menthols have been presented as a healthy, smooth, candy-like, medicinal-like. The word medicinal has actually been used in advertising factors. So one, it's a starter drug for kids, and the industry willfully and predatorily did that. Two, it has been marketed historically from the 30s forward as a harm reduction method, which is a total farce and completely untrue. And then finally, just to state the obvious, it has been the predatorily pushed on African Americans and other groups, such that 80% of African Americans currently smoke menthol. Most of them smoke the Newport brand, which incidentally is the company we were in litigation with Lorillard for 5.5 years. And you know, it says it all when their main branding message for that particular pack, Newport, is alive with pleasure instead of dead as a doornail. The second topic I would like to discuss is one that's been subjected to some very current controversy, and that is e-cigarettes. To many people, it seems intuitively straightforward. Just pick up an e-cigarette, and I'm sure you know what they are. They do not contain they do not contain tobacco. They do, however, contain nicotine, most of them, but not all. Our position at Legacy, which is on our website, is that none of these products should be on the market until they are tested for safety. We do not believe that just because someone is trying to quit, it should be open season on them for whatever product comes along the pike. But personally, I would like nothing more than to see that evidence realized. I was, as Greg alluded to, a smoker. I wasn't just a smoker, I was a chain smoker. I smoked over 3 packs a day. My mother was one of 16, 13 lived to adulthood. All 10 who have died of tobacco-related causes. My mother died smoking what I estimate was her 1 millionth Pall Mall when she dropped dead of a massive coronary at age 62. I've lost aunts and uncles to lung cancer. I have one living with lung cancer, and my other 2 living aunt and uncle have had triple bypasses. So I have a lifelong history with tobacco as a killer, and it was very, very hard for me to quit smoking. I was the associate dean of an Ivy League school of public health and a chain smoker at the same time. Now, if that isn't the ultimate in irony, I mean, it's not quite being a smoking president, but it's close, you know. So I know it's very difficult, and I would love it if something like e-cigarettes actually help people. I've now seen 2 studies that e-cigarettes actually don't deliver the nicotine that's on the label. So my guess is at the end of the day, it may turn out that they are not that efficacious. If it does turn out that they're efficacious, I think they should be on the market. Then I just want to wrap up by saying, you know, how can we take full advantage of the FDA regulation as currently written? And it's only as currently written. It can be amended. First, I want to say, how is it that it got passed? People are appalled by the negatives in it. You know, you can't medicalize cigarettes under it. You can't bring nicotine to zero. The tobacco industry has a seat on the scientific advisory committee. I mean, there are many absurdities. It got through because, sadly, in this country, nothing gets through the federal government in the tobacco arena without at least some tobacco company nodding yes. And the reason for that is appalling. It is because our Congress has been bought and sold with donations to their elections by the tobacco industry. The range is between 50 and 75% of all politicians in the whole country, state by state and within the Senate and with the House, take donations from these guys. So it's no different than what's happening to health reform. We're seeing, you know, we're seeing a bill that could have been really quite ideal, totally transformed because of the political power of lobbyists. So we've got what we've got because we have a rotten system that allows strong and powerful and rich industries to essentially write legislation. So we have a lot on our plate now. What we have to do is be certain that this bill does the maximum amount that it can to improve the health of the public. We are going to need very, very rigorous research. We are going to need a system for very rapid research in order to be able to get answers to very practical questions in a very short time frame. And I won't go into all the details of what that will entail, but there are many, many people, many groups working on how that can come about. We're hosting a meeting at Legacy very soon on that topic. Greg has given this topic a great deal of thought, and others too are working on it. For the first time in decades, we have fewer smokers in the United States than former smokers. We're at about 45 million current smokers, adult smokers, and 46 million former smokers. Effective counter-marketing, along with clean indoor air laws and increased federal and state excise tax, have been a powerful trifecta in combating this epidemic. So wherever you land on the FDA regulation of tobacco, the fact is it is now law. It's here to stay. I think we should stop the Monday morning quarterbacking and work to see that it succeeds to the best of its ability to save lives. Thank you.
Thank you, Cheryl. Our next speaker is Patrick Basham. He's the founding director of the Democracy Institute, an independent think tank based in London and Washington. He previously served as a senior fellow at the Cato Institute, where he is currently an adjunct scholar. Before that, he served as founding director of the Social Affairs Center at the Fraser Institute, where he led the Institute's tobacco regulation research. He has taught tobacco regulation and other health policy courses at Johns Hopkins. He's written, lectured, and commented extensively about regulation of the tobacco, food, and gambling industries. He has presented his research before domestic and foreign government commissions and committees, most recently at the House of Commons in London. He is the co-author of Hidden in Plain Sight, Why Tobacco Display Bans Fail, and is co-author of the UK bestseller Diet Nation, Exposing the Obesity Crusade. He wrote his Cambridge University doctorate on American politics. His articles have appeared in the British Medical Journal, the New York Times, the Washington Post, Forbes, and The Independent. Mr. Basham, Dr. Basham, please.
Thank you, Bob, for your kind introduction. Good morning, ladies and gentlemen. I'm sincerely honored to be a small part of today's program, and to appear on the same panel as Greg and Cheryl and Michael. And I'm grateful to the School of Public Health's generous invitation, some might say unsafe invitation, for me to be with you today. However, I must admit to a certain trepidation on my part, given that as the author of a book that criticized in the strongest possible terms the late Senator Kennedy for his support of FDA tobacco regulation, somebody here has cunningly asked me to speak on the very same topic in Boston, of all places, at a prestigious school of public health, no less, within weeks of the great gentleman's sad passing. So I conclude perhaps the rumors are true. Despite his outward charm, Professor Siegel may actually want me done away with. Less seriously, I'll spend the rest of my time, Greg made a number of very interesting points, many of which beyond the scope of the specific question that I'll address in the rest of my time, but I'm sure that between us all here, we will get into many of the interesting statements that were made earlier. But I'll start off by simply telling you where I stand on this important issue of safer cigarettes. I suggest to you that any effective tobacco policy will devote substantial resources toward developing safer cigarettes. This follows from the recognition that, like it or not, smoking is most definitely here for the long term. And a morally justifiable tobacco policy must not only acknowledge this fact, but also accommodate it. The new FDA legislation does not do this. Indeed, as argued elsewhere by others and by myself in my book, the new legislation not only fails to provide a welcome for harm reduction, it appears to go out of its way to make it difficult, if not impossible, to reduce harm. In this sense, it prefers to sacrifice the lives of existing smokers to the unsubstantiated worry, in my view, that safer cigarettes will not be in the interest of public health. Again, in my view, this is an indefensible position. As such, an effective tobacco policy needs to begin by recognizing it as that, indefensible. To prevent, either directly or through manipulation of the scientific risk assessment process, the discovery, testing, manufacture, and ultimate sale of cigarettes that might save the lives of smokers is both unwise and unacceptable tobacco policy. Now, to step back in time for a moment, the great and often prescient left-wing writer George Orwell last century expressed early doubts about the efficacy and the morality of the then embryonic nanny state in his country. Orwell reminded the political class in England that, quote, "No doubt tobacco is something that a saint must avoid, but sainthood is also a thing that human beings, especially legislators, must avoid." Unwittingly, some may say involuntarily, Orwell's present-day American disciples are the 10 to 15% of the population that will continue to smoke regardless of what the federal government or any government at any level does or does not do. Given that stubborn reality, it seems justifiable, to me at least, to make this process less risky, even if there is a slight increase because of the reduced risk in the total prevalence of smoking. At the very worst, even with such an increase, the total mortality burden of tobacco use will be reduced. Aside from any population-wide public health benefits, such a policy would make an enormous difference in the lives of individual smokers. A significant benefit, I suggest to you, for a still significant, if increasingly beleaguered and much maligned subset of the population. Such a policy does not mean, however, that the tobacco industry should be placed in the driver's seat in terms of developing and marketing these products without sufficiently rigorous regulatory safeguards. These safeguards must ensure that at the end of the day, these products deliver what they promise. It also means there should be public recognition that no regulatory regime can guarantee any product's absolute safety. In an ideal world, what might such a regulatory process and policy with respect to reduced risk cigarettes look like? I think the regulation of less hazardous cigarettes should begin by recognizing the necessity of gradual changes from traditional to progressively improved cigarettes. Once this fundamental premise is understood and appreciated, an initial step would be to establish a point of departure, a benchmark against which to compare future improvements. There will be various ways of evaluating hazard reduction. The simplest is the attainment and recognition of an overall reduction of exposure and dose. The more complex and uncertain way is the evaluation of hazard after the reduction or elimination of undesirable smoke components. In a third option, dose reduction could be evaluated by the reduction of tar and nicotine ratios from modified cigarettes. In considering tests, it will be necessary to decide which endpoints to address and which tests may be appropriate. For example, tests for carcinogens may not be a realistic option because decades of attempts have failed to reliably cause lung cancer or other diseases in animals by smoke inhalation. The groundwork for the evaluation of an improved, that is, a less hazardous cigarette, should be a thorough chemical characterization complemented by a detailed description of the modifications and the processes employed. It is conceivable that certain models of modified cigarettes may receive rapid but time-limited approval, therefore ensuring brief exposures and the minimization of possible mistakes and misjudgments. There is another important consideration that would make the regulatory task much easier. Traditional precautionary principles could be applied to cigarettes, but in reverse, making it much easier to judge the reduction of a known risk than to certify the probable absence of risk. Now, this suggested process and policy is not the only plausible one, of course, but it has the merit, in my view, of combining realism about what is being attempted, that is, reduced risk as opposed to complete safety, transparency of process, and scientific rigor, all of which satisfy the process requirements of good public policy. Most of these suggestions stand in stark contrast, I suggest to you this morning, to what was passed through the Congress this year under the guise of serving the interests of public health rather than, as I and some others have dared to argue was the case, serving respective corporate and political interests. However, by bringing the crafting of tobacco policy out of darkened back rooms into the light of day, by taking it out of the hands of the special interests, by ensuring that the FDA adopt an evidence-based approach, there is maybe, just maybe, an opportunity to shape a policy that actually serves the interests of public health. Now, such regulatory objectivity does not mean that the regulating agency is neutral about the desirability of smoking. The FDA clearly takes as its core function the reduction of smoking, but it does mean that at the outset, of its regulatory work, it has not predetermined what its regulatory course will be. in advance of considering all of the evidence, either on its own or through imposed congressional instructions. But enough semi-optimistic so-called happy talk from me, and so much for a regulatory glass half full. It's important that none of us be fooled by those rascals who've already been well characterized and described by previous speakers, those rascals in Washington. After all, many of us were indeed born at night, just not last night. The uncomfortable reality we face this morning is that this legislation is simply bad news for public health. To cite but one example, but the example most pertinent to today's question and debate, it pretty much guarantees that no truly safer cigarette ever reaches the American consumer. Let's not lose sight of the fact, I suggest to you, that the FDA appears to have an institutional come cultural bias against safer cigarettes. Such a bias does not serve the public's interest. Those of us who've had the fortune or misfortune to spend large amounts of time in discussion with current and former FDA officials can attest firsthand that the FDA has always been worried about being involved in safer cigarettes, both in terms of perceptions about the agency and in terms of FDA staff having the necessary competence. The agency simply doesn't have any staff that's used to thinking about how you make an unsafe product relatively safer. This truth, of course, underpins the anxiety in some corners of the public health community that an FDA without its own scientific expertise will simply adopt the prevailing industry standards and experience. Now, as far as I can tell, the process of validating new reduced risk products appears to be designed to prevent such products from ever reaching the marketplace, thus giving smokers the stark and, for many, the impossible choice of simply quit or die. So, rather than making smoking safer for those who continue to smoke, the FDA may deny smokers access to new products that might literally save their lives. In closing, I respectfully suggest to you that that's hardly a sterling prescription for good public health. Thank you very much.
Thank you. Our final panelist is known to many of us. Michael Siegel is a professor in the Department of Community Health Sciences here at Boston University School of Public Health, where he also serves as the Associate Department Chair. He's a physician whose primary research interest is in the area of tobacco control, focusing on secondhand smoke effects, exposure, and policies. He is also interested in cigarette advertising and marketing practices and their effects on youth, and evaluation of tobacco control policies and their impact on youth and adult smoking behavior. His primary teaching is in the areas of mass communications, marketing, and public health advocacy. He's the co-author of a book, Marketing Public Health, Strategies to Improve Social Change, which grew out of his teaching experience at the school. He has been active in promoting smoke-free bar and restaurant policy throughout the country and has served as an expert witness in several major tobacco litigation cases. Michael completed his residency in preventive medicine at the UC Berkeley School of Public Health and trained in epidemiology for 2 years at the CDC in Atlanta before coming to Boston. He is a prolific op-ed writer and blogger and is sought after expert analyst by national media outlets on the topic of tobacco control. Michael?
Thanks very much, Bob. It's really a great honor to be invited to be a panelist for the Bicknell Lectureship. And when Bob first invited me to speak, I said, I'm really honored that, you really want me to share you recognize my tremendous insights in tobacco control and my tremendous expertise and knowledge, and you want me to share that. And Bob said, we're not inviting you to speak for your insights and experience. We just need a physical body to put between Greg and Patrick. So I'm very happy to serve that role. I am really honored to be here. And first of all, it's really an honor to be here with Greg. my research has shown that I think Greg spearheaded what is arguably the most successful public health intervention of my lifetime, which is the Massachusetts Tobacco Control Campaign. Under Greg's leadership, this campaign resulted in, according to my research, a 50% reduction in youth smoking initiation, which is really an unprecedented public health effect. I mean, you know, when you look at major public health campaigns, if you see a 3 or 4% decline in a behavior, it's really a tremendous impact. So to see a 50% effect, you know, this is really a model for public health programs. So it's really an honor to be here with Greg. Cheryl is now taking the Massachusetts experience and really spearheading it at a national level. And recently, very similar research to what I had done in Massachusetts confirmed that the Truth Anti-Smoking Campaign has a very similar effect, the same degree of magnitude in reducing smoking initiation nationally. So it really is an honor. I also want to say that it's an honor to be here with Patrick because he was a little bit modest in you know, promoting his book. So I'm going to do it for him and just say that I think that anybody, before making a decision about your evaluation of the FDA legislation, you really need to read the book because he really exposes the truth behind how this bill came to be. And I'm going to give you a few excerpts from a few hints at what's in there as I talk. I want to address both of the parts of the symposium title, and I'm going to go backwards. First, I want to talk about the FDA regulation of tobacco, and then second, I'm going to answer the question, is there a safer cigarette? And being an academician and not somebody who's in government or public policy, I'm going to give you an answer. Okay. First of all, I want to make the point that, in my view, the FDA law is an absolutely absurd approach to the tobacco problem. And I want to make it clear that I'm not arguing here that the regulation of tobacco per se is absurd. What I'm arguing is that this particular approach is an absurd approach. And let me tell you what I mean. Greg mentioned that there were several cigarette companies that put out products that advertise that they have reduced carcinogens. And at least for some of those products, they had documentation that these products delivered lower levels of carcinogens. So Omni came out and said, reduce carcinogens. Accord came out and said, reduce carcinogens. Eclipse came out and said, 80% less carcinogens. Well, what was the response of public health groups? The response of public health groups was to attack those companies and say, how dare you? How dare you come out on the market with a product with reduced carcinogens? Why? Why did we attack those companies? Well, we did it for two reasons. One, reduced carcinogens does not mean a safer product. Reducing levels of carcinogens in the product, there's no evidence that simply reducing levels of specific carcinogens in the product results in a safer product. We all acknowledge that. And secondly, simply producing a reduced carcinogen cigarette could have adverse population effects. Because if people think that cigarettes are safer, more people might smoke. And so in the long run, it could actually do more harm than good. So what does the FDA legislation do? The FDA legislation says to the FDA, we want you to reduce some of the carcinogens in cigarettes. So essentially what we're saying is that when cigarette companies reduce their carcinogens and advertise that to the public, they're to be attacked. But now we're giving the FDA that exact same charge. We're telling the FDA, the way we want you to regulate this problem is pick some of the carcinogens and mandate a reduction in their levels. And so what this is essentially doing is, instead of cigarette companies coming out and saying, we have a reduced carcinogen product, now the FDA is going to be coming out and saying, we now are going to be mandating a reduced carcinogen product. The problem is there's no evidence. The same criticisms that we leveled against the cigarette companies are going to hold for the FDA. There's no connection necessarily between the level of the carcinogens and the safety of the product. And secondly, this may actually have the adverse effect of giving the public a perception that cigarettes are now safer, and as a result, increasing smoking rates. This approach would make sense if there were 3 chemicals in tobacco. If there were 3 chemicals in there, it would make perfect sense, because then the FDA could say, you know what, we've got compound A, compound B, and compound C. So what we're going to do is we're going to require reductions in these 3 compounds. And we would know that, you know, that's almost certainly going to result in the protection of the public's health. But tobacco smoke has over 10,000 chemicals in it. And so how is choosing a few of those chemicals and lowering the levels some sort of rational approach to dealing with the problem? Moreover, we don't know what 50 to 90% of the chemicals are that are in tobacco smoke. So one of the things that the FDA legislation is touted for is that finally we're going to know what's in there, because the cigarette companies are required to disclose what's in the product. Well, the cigarette companies themselves have only identified 4,000 compounds, but we know that there are at least 10,000 and perhaps as many as 100,000 in there. So what good is it to know 40% of the products, of the chemicals that are in there? So, you know, are we going to tell customers, well, you know what? We know that 40% of what's in there, so you should feel reassured. You know, we have no idea what else is in there. So how can we go about creating a safer cigarette when we don't even know what's in the cigarette? Also, I think we have to recognize that what this is essentially doing is giving an FDA seal of approval to cigarettes. The cigarette companies can now rightfully come out and say, Marlboro adheres to the strictest federal standards. We are concerned about our customers' health, and we want to assure our customers that we now adhere to the strictest federal standards. What does a safety standard mean when you're talking about a deadly product? The bottom line is these products kill people, and they're going to continue to kill hundreds of thousands of people a year, no matter what the FDA does about it. So is it going to be some consolation to the families of the people who are dying from cigarettes? Are we going to be able to console them by saying, you know, we're sorry to hear about your loss, but at least you can be assured that they were smoking a federally approved cigarette? Okay? This is not a consolation. The other problem is that it puts the FDA into the business of approving deadly products. And I think we have to think about the broader public health implications. Is this something that is a really appropriate task for a federal health agency? I think it really undermines the entire federal system of health regulation to put a federal agency in the business of approving deadly products for sale. Because as soon as the FDA takes on regulatory authority, what it basically means is that the FDA is approving the current cigarettes on the market. Every day that the FDA fails to take an action to either take them off the market, which they can't do under this legislation, or to somehow miraculously come up with a safer cigarette, they are approving products that are killing people. So the FDA is now complicit in the tobacco epidemic. And worst of all, what this legislation has simply done is shifted the fraud that the tobacco companies have committed for years, or that we've accused them of committing, over to the federal government. Because now, instead of the tobacco companies experimenting with reduced carcinogen levels and misleading the public by saying there are reduced carcinogens, this is a safer cigarette. Now it's going to be the federal government that is mandating lower levels of carcinogens and other changes of which we will have no idea whether they are actually going to improve the public's health. Essentially, it's the federal government that's now going to be fraudulently deceiving the American consumer into thinking that these products are safer when we actually have no evidence for that. So essentially what this legislation has done is simply taken a lot of the burden off the tobacco industry. And it's basically said the FDA is now going to take responsibility for the safety of the product. You no longer have to worry about it. Now, let me get to the answer to the question, is there a safer cigarette? I think that it depends on how you frame the question. I think that I'd like to break that down into two questions. The first is there a safer cigarette? And the second is there a safer cigarette in terms of what the FDA can do? Okay, two very different questions. So let me address the second one. Is there such thing as a safer cigarette in terms of what the FDA can do? And I think the answer to that is clearly no. Because by tinkering with the ingredients, you're not going to create a safer cigarette. Like I said, we only know a small fraction of what those ingredients are. So yeah, you can reduce some of the carcinogens. You can play around and tinker with the product. But we have no way of knowing whether those changes are going to result in actual reductions in disease. Greg, I think, very nicely pointed out the problem, which is that we can measure the reduced exposure, but we don't have biomarkers that can translate how that exposure relates to actual disease risk. And so, no, we're basically in a situation where we can't produce a safer cigarette, where we don't have the scientific knowledge to produce a safer cigarette, where we won't even know if we have produced a safer cigarette if we've done it. The FDA is being put in a position where it can no longer use science to guide its actions because we don't have that science. We don't know the answer. Nobody does. Even David Kessler, who was probably the strongest proponent for FDA regulation, admitted, quote, "We don't know if it's even possible to create a safer cigarette." So if we don't know if it's possible to create a safer cigarette, why have we charged the FDA with that impossible mission? It essentially is just a wasted bureaucracy, creating another bureaucracy that can't possibly fulfill its mission. Is there such thing as a safer cigarette? Well, there is. There is. And I've got it right here. No, it's not my pen. This is a safer cigarette. This is an electronic cigarette. This product, I have loaded in here a glycerin cartridge, which has nothing but glycerin in it. And when you smoke this product, there's no tobacco in here. It's pure glycerin, but it produces a vapor that can be inhaled, and it even lights up at the end here to make it look like the end of a lit cigarette. And when I exhale, I will puff out a puff of vapor. So for the cigarette smoker, it's able to entirely simulate the smoking process. Yet it's completely safe. It is a safe cigarette because the only thing in here is glycerin. Now, so yes, there is a safe cigarette. I'm holding it. There's absolutely no risk to using this product. It's like puffing water vapor, okay? Unless you think puffing on water vapor is dangerous, we have a safe cigarette. The technology is here, okay? There are two issues. One is that smokers are probably not going to want to puff on a glycerin cartridge. They're going to want a nicotine cartridge, okay? So is a nicotine cartridge safe? Well, no, it's obviously not safe. The question is it safer? And I would argue there's no question that puffing on a nicotine cartridge is got to be safer than puffing on nicotine plus 4,000 other chemicals. It doesn't take a rocket toxicologist to figure out that nicotine is going to have less health effects than nicotine plus 10,000 to 100,000 chemicals, which includes 60 known carcinogens. So the question is not, is there such thing as a safer cigarette? The question is whether the framework that was set up in the FDA regulatory authority enables the FDA to create a safer cigarette. And I would argue that it doesn't, because it essentially gives the FDA this charge of creating a safer cigarette by simply reducing levels of carcinogens when they have no idea what the connection is between those and the public's health. And I really want to come back to one of Patrick's points, which is that if anything, this bill precludes the possibility of safer cigarettes coming on the market. And why does it do that? Because it puts an impossible burden on the introduction of new products that would potentially be safer. So if a cigarette company wanted to come up with a product like this that had maybe a little bit of tobacco in it, it will never see the light of day on the market, because they have to prove that this would be appropriate, that introducing this product onto the market would be appropriate for the protection of the public's health. They would have to prove that this actually reduces cancer and heart disease. Well, how many years does it take till we know if it reduces cancer or heart disease? It's going to take 10 to 20 years to know that. And they have to have that data before they market it. But you can't get that data unless you market the product. So it's a complete catch-22. You can't put a new product on the market unless you show that it's safe. But you can't show that it's safe until it's on the market. So the FDA legislation creates an impossible barrier by which no tobacco company will be able to come out with what could be a truly safer cigarette. I want to close by just pointing out a couple of what I think are broader public health issues that we really need to think about, and that this tobacco issue really brings to light, but I think are relevant to basically all issues in public health, or many issues in public health. The first is, does it make sense to have the federal government approving a deadly product? And I think that this legislation in the long run is going to have the effect of undermining the entire system of federal regulation, of federal health regulation. It sets a terrible precedent for the federal government to be essentially endorsing and approving a product that's going to kill people. That is simply not something the federal government should be in the business of doing. Second, I think that it really should get us to think about the terrible inconsistency in federal regulation. Here, the FDA is approving cigarettes for sale, yet we're asking them to ban these electronic ones. The third thing is, I think it asks the important question of, is legislation worth passing if it has to be watered down so much because we need to compromise with industry in order to retain their support for the bill? And so what Patrick's book talks about is the fact that this bill was not crafted by Senator Kennedy. The bill was not crafted by public health groups. The bill was crafted by Philip Morris. Everything that went into this bill went in there with the blessing of Philip Morris. Anything they didn't like, they said, take it out. And so the question is it possible to have effective public health legislation when you have to appease industry in order to get that legislation passed? And I think this is very relevant to the healthcare reform debate that's going on today, is the question of, if you need to have the insurance industry approve your legislation, is it even possible to have legislation that's going to reduce healthcare costs? And I think that's something we need to seriously think about. Thanks very much.
Thank you, Michael. Thank you to all the speakers. You've managed to hit the speaker trifecta of being provocative, on point, and on time. So right now we're going to take a break. We will resume at about 5 after 11 for a Q&A session. Thank you. I think it's appropriate on Alumni Weekend that a member of our alumni board comes up for the first question. Doreen?
Hi, I want to thank you very much.
Wow.
I wanted to thank you very much. Can you hear me?
now.
I went to the Howard Zinn lecture series last night, and I was very struck by how the parallels of these two lectures. I had two takeaways from that session last night. And as Howard Zinn said, capitalism, or the politically correct free market, is really at the expense of our society. And what I learned today is also at the public health of our society as well. And that's one of the comments I wanted to make. The other one was, takeaway that I came away with, is that he talked about grassroots movement and how important it is. And as a public health professional and how we want to shift the view of public health in our society, what are some of the ways that we can do that? And in terms of a social marketing campaign, I'd like to know how you would plan to integrate social media and marketing into a public health campaign that looks at your messaging. Thank you.
Well, maybe I could answer the last two. FDA is going to have a fee which will generate significant dollars, and they could do contracts with communities and states to implement the legislation around not selling tobacco products to kids. But I think that, to me, is a very broad issue. Not selling tobacco products to kids includes health communications. It means community-based messaging. I showed you an ad that you could put on and vary that by state, put that in any warning label sold on a pack of cigarettes, have a 1-800 number that links to a local quit line. I think we've had enormous technologies, but it has to be grounded in communities of America. One of the big problems we have right now is this bill is viewed as, like people say today, a Philip Morris Beltway deal between a handful of people, and it's not America's bill. I think the only way we're going to make this bill work is to ground it in the communities of America by sharing the resources, by having them be active with provisions of the bill. We're talking to the City of Boston. The City of Boston's been a leader on ban of sale of cigarettes in pharmacies. The bill allows latitude for the cities to do things relative to advertising on point of purchase. There'll still be legal challenges, I'm sure, but can we empower communities to exceed the bill, to complement the bill? I think it's just how big you can dream that can create a better future around around tobacco control in the United States, and I think there's some really great opportunities. I think the people under this administration have a really good attitude. I can't speak what may occur if this president leaves, but I think, and I'm willing to take a risk that if we make those connections with the communities, that we can make this, we can knock smoking rates down in America with the bill. And that's the key, is getting the rates down. It's not trying to come up with something that's going to be, viewed as less safe or less harmful.
Cheryl, your organization has been involved in a large media campaigns.
Yes, American Legacy Foundation has spent on an average of $100 million a year since its inception in 2000 on counter-marketing tobacco. Principally, and vast majority of those dollars went into something called the Truth Campaign, which, as Mike was kind enough to point out, recently in longitudinal studies, in addition to some cross-sectional studies before, have been demonstrated to be highly efficacious in stopping young people from smoking. The underlying philosophy of the campaign is to rebel against the tobacco industry. Don't smoke, not smoking in order to rebel. And they're very hard-hitting. They're very anti-industry. They have one of their clear goals to help young people have enough information that they can conclude that the tobacco industry lies to them and is after them as replacement smokers to keep everything going. That campaign has a strong grassroots component. We go to 6,000 communities. Most summers we touch 6,000 different communities coast to coast, attached to Van Warp's tour and very much involved in alternative media on the internet and through Twitter and mobile technology. So the campaign has been very successful, but I think the point that the questioner was making is an extremely good one. We get legislation like we just got that is imperfect because of the absence of a strong grassroots community movement. And in the states that have been successful, the most successful states in tobacco control have largely been referendum states where the people have the opportunity to circumvent a bought-off legislature.
Next question.
Dr. Connolly, in 2005, you released a study on reduced ignition propensity cigarettes, otherwise known as fire-safe cigarettes. In the study, you wrote, more research is needed regarding how smokers smoke RIP brands versus non-RIP brands and what their exposure is to the disease and toxins. In May, before any such study was done, you told the Boston Globe it would be a no-brainer to mandate such cigarettes in the state of Massachusetts. Considering there are about 12 deaths a year attributed to cigarette-caused fires and 1 million people smoke in Massachusetts, was this what you call cautionary?
Thank you. I really enjoy having people like yourself come and listen to me. Let me just try to answer questions. You know, one, things aren't mutually exclusive. If you can make a cigarette so it's less likely to ignite, you're not telling anyone it's any safer. And there's been no claims that any low-risk cigarette is any safer by any company, and that's why we do it across the board. Number one. Number two, we have always held that the fire-safe cigarette standard, not on the issue of harm, but really as an intermediary standard. This is when we require cigarettes to go out when burning through a double wrap paper. We have about 800 deaths per year at a large number of fires. Industries have the technology where you can put a double wrap of paper and it goes out. If you do that, when the cigarette falls on a 10 cell layer similar to upholstery or bedding, it will by and large not do a full burn, so you'll reduce the likelihood of a fire. The Surgeon General in 2000 said, if you can do a technology but not make a claim, you should do the technology. Instead of responding to Mike's question, if you can take nitrosamines out and not tell anybody, should you do that? I kind of think yes, but I'm not really sure, because the industry in the past, no matter what we do, somehow takes what we do in terms of doing a known technological fix, and they use it to their advantage on perception of reducing risks. If you look at the performance of cigarettes, cigarettes perform so widely, and you know, and we all know this, that they're a highly lethal product. It's nothing like it. Altering at 10 or 5% is not going to make a difference in lethality. The big question in RIP, and I'm not probably answering your question, is it working on a population level? And I don't think we really know that yet. And we have always called the standard an interim standard. But as an interim standard, it should be adopted right now. There's no question, because all the science would say it's going to reduce fire deaths. And there's a woman just a few blocks down from this building in West Roxbury who has 3 grandchildren who are buried in Mount Calvary Cemetery. Not Mount Calvary, but in cemetery in West Roxbury, where their house burned. I think for those 3 children, if there was a fire-safe cigarette, that wouldn't happen. But let me get to my point. We need to evaluate or validate the laboratory evidence on fire-safe cigarettes with the actual population effect to see if we're getting a reduction in the fires that we anticipated. One of the difficulties we have is the fire reporting system in America is not strong. Firemen often report after they've been into a hazardous situation, they fill out the form and they leave. And so that's a project we're working on right now. I think if anything, we could probably up that RIP standard right now than we have. We've just completed urine measurements of Massachusetts smokers, so we switched from non-RIP to RIP cigarettes, and we saw no difference in exposure to CO, anthracene, gas phase, particulate phase. So, you know, the cigarette's a lethal thing. I mean, if you tinker with it, you know, you're really tinkering with a bullet going at you 200 miles an hour. I think what the key is to prevent that bullet from being pulled in the first place.
First, I wanted to thank you all for each talk was really provocative and very, very interesting. Just following up, I wanted to try and see if I could summarize accurately what I think is sort of a key issue maybe for many of us sitting in this room, which is as public health professionals, we're, of course, interested in reducing harm. And I think everyone on the panel is interested in reducing harm. What I'm hearing, and please tell me if I'm right or wrong, is that perhaps Greg and Cheryl would say, yes, we're reducing harm, but that can only be considered on a population basis. I mean, that this issue of individual versus population harm, we have to get to be able to know that whatever changes we make a difference at the level of the population. I think what I heard from Patrick was that that's not really ethically acceptable if you have something that you know can reduce harm among individuals, that you need to move forward on that. And then I think what I heard from Mike was, yeah, it should be on a population basis, but this bill is not going to be able to do that. So first of all, I'd like to understand if that, in fact, is where the differences might lie. And then just since while I'm up here, in addition to that question, get my second question in, which is, it's kind of ironic that the FDA is now getting to regulate cigarettes, because there's been all these issues with how they regulate the therapy to treat cigarette addiction, which is nicotine replacement therapy. And when Mike was explaining about the e-cigarettes, it sounded like the e-cigarettes are really nothing more than a nicotine delivery device. And so I'm wondering why they're even in the category of cigarettes as opposed to another form of nicotine replacement therapy treatment, in which case they should be able to be evaluated in that way and perhaps get a lot more likelihood of being approved.
Michael, why don't we let you tackle the second question first, because the first question is a bit more complicated. So what about this issue? Is it not just why is it different from a patch? Why do we call it a cigarette at all?
Well, I think you're right. I think it is a nicotine, it's clearly a nicotine delivery device, and I think it should be regulated as a nicotine delivery device. And I don't think that's where the controversy is. Where the controversy is what do you do while the e-cigarette companies are doing all the studies to demonstrate through clinical trials that the product is, quote, safe and effective. I think that's where the real issue is what do you do in the meantime? And so there's one school of thought that says we need to pull these off the market immediately and recognize that it takes, the average amount of time it takes to get a new product approved is 8 years. So we're basically talking about pulling these things off the market for at least 8 years while these studies go on. And then there's another school of thought that says, and which is my opinion, which is that you've got hundreds of thousands of people who are now ex-smokers. And they're ex-smokers because they're using this product. We know that this product is safer than smoking. Why would you basically force these people to go back to cigarette smoking while they have to wait 8 years? I mean, they're not going to be around 8 years later to see this product. And so I think that's really the issue. I think you're right that from a regulatory framework, this is a nicotine delivery device. It's going to be regulated that way, and the FDA is going to treat it that way. The question is, what do we do in the meantime? Do we pull it off the market while we're waiting, or do we allow it to be continued to be marketed and used?
Well, let me just add is that, I mean, that's one product of probably 10 products that have come out this year, of which 150 others have been out over the past 10 years. And just to pull one product out and say, okay, we're going to treat this thing differently, the other 150, I think may be unfair. I think what we're saying is, when the FDA bill has capacity, we need to bring some science into this. It's just not enough for Mike Siegel to stand up in a room and say it's safer. I have to trust, and I trust you as a good scientist, and I hope you would advise the FDA, but I would like to see on their website more information about what's in their packet, what is the exposure to nicotine. It'd be nice to know, are people, are kids in pubs in Boston smoking e-cigarettes out inside the pub and then going out and lighting up Marlboros? I mean, when we bring knowledge to public health, the bigger the body of knowledge we have and the better that knowledge is, the better off we are. And if we have a framework, a risk assessment framework with weight of the evidence, the better off we are. I see the value of the bill not so much as promoting newer products as taking the barn door, which is already wide open with lights. 85% of Americans smoke lights. Many believing they're safer, many perceiving they're safer, and we have no control over it. And right now we're seeing them just change the term to a different color, and we have no control over lights under the FDA bill unless we say to them, hey, you got to come in as a modified risk product. I'm sure when faced with, I mean, I'm not sure, but I think FDA is going to have to come up with some rapid triaging assessments. And if you do have a product, it's fine and it's safe, and they're not going to go after kids in bars. You know, okay, let's get that in the marketplace. Let's in this whole culture of the FDA stink culture with it, which is in public health today. You got to read Phil Hiltz's book, History of the FDA. It goes back to 1906. That agency is really a marvelous, marvelous public health agency, dealing with thalidomide, dealing with fast-tracking AIDS, dealing with many, many public health issues. So I'm reluctant sometimes to trash FDA, given the fact that the past few presidents have done their best to trash the agency. That agency has a lot of good folks, and in fact, I think a graduate of this school is now the deputy commissioner of FDA, which makes me even more hopeful that we're going to see something good come out of it.
Cheryl?
Well, I would just add that I think a product like e-cigarettes ought to be able to get through the approval process in less than 8 years. And I think there's every reason to believe that it could and should. I personally think the probability that e-cigarettes will become an entry smoking device, or a device that people go back to, have quit for years, is probably minimal. And I think that can be studied in the short term. What I do become concerned about is this notion that, well, it seems logical that it's safer, so therefore let's let it be out there until we prove otherwise. And I think if we go on that slippery slope, we'll do a lot of things that we just don't believe in doing. I mean, you know, Mike, you and I have debated the whole issue of lung cancer screening and the various bodies of evidence on that. And you know, you strongly believe until the full results of a randomized clinical trial are available, no amount of observational evidence would outweigh that. And I totally appreciate and understand your view on that. What I don't understand is why, when it comes to e-cigarettes, and believe me, I know the two are apples and oranges, you say, well, you know, we don't need the research. There is at least one ingredient in that is not approved for human consumption. And we have 2 studies out there saying that it's basically a consumer fraud because it's not delivering nicotine. So any state AG could decide to go after it just on the grounds that people are paying a lot of money for something that they think is a nicotine delivery device that isn't delivering it. So I would say fast track it. I would treat tobacco cessation aids the way we treated research for HIV. I would put it all on a very fast track, because I completely agree with you that people shouldn't wait 8 years to find out if a nicotine delivery device is doing that and working to help people quit. And I think there are many theoretical reasons to believe something like the e-cigarette would in fact work. That's why I said in my own remarks, you know, if it had been around when I was trying to quit smoking, it has some obvious intuitive advantages. It lets you model the act of smoking, which is what many of us miss enormously. In my case, I missed that and the nicotine. You know, and my road down pharmacotherapy was I chewed Nicorette, I put patches on through my stockings, and as soon as no one was around, I smoked too. I mean, I was an unmitigated disaster. So none of it worked for me in the way it's supposed to work, but eventually I quit, so somehow I quit. So I'm a big fan of getting this stuff on the market and getting it on fast. And I think, you know, getting a commentary out there saying this stuff has to be on an accelerated path, and there's no reason why it can't be on an accelerated path, you know, is the right way to go.
Patrick, did you have a comment on e-cigarettes?
Well, I have a large sort of comment on the larger question of the FDA. I mean, let's assume for a moment, and some of you would like to assume for more than a moment, that everything that I've said and written about this bill, everything that Mike's said and written about this bill is completely wrong, okay? So we all know the bill is fantastic. It couldn't be any better. It's going to do the business. We still would face the problem of tobacco being regulated by an agency that's incapable of doing the job. That's not my opinion. It's the opinion of the people who, prior to President Obama's term, ran the agency. It's not a question of them being bad people. It's a question of probably too few good people having the time, resources, and the skills to do the job. So even if we were going to take this legislation and run with it, the last place that we would take it to and say, this is your baby now, you own tobacco, is the FDA. So we are just going to continually bump up against this problem of it being in the wrong place, being regulated by the wrong people, and not just today, but as Cheryl was saying in her comments earlier, for the foreseeable future.
Cheryl?
I would just make a couple of comments. One, I would just remind the audience that the bill itself prohibits the tobacco industry from describing their products as FDA approved, number one. Number two, the individual who made those statements was, I think, off the farm in the view of many in the administration at the time. And that was Andy von Eschenbach, you know, a well-known oncologist from MD Anderson in Texas. And he didn't want the burden on his agency, and he said so spontaneously. But that does not mean that the FDA, with a funding stream of $700+ million a year, a few short years from now, cannot gear up to be able to do this job. They've already started to gear up. You know, they just recruited, and she starts next week, the person who essentially ran the Office of Tobacco Control for a number of years at the CDC. They're able to rise to the occasion, and believe me, there's no one in FDA that doesn't get the absurdity, you know, that they're in the process of regulating the most lethal drug as it's presently delivered in the U.S. They get what they're doing, and what is the alternative? The alternative is to make it illegal, and that opens up the whole Pandora's box, you know, which we're not discussing here. I think that's a whole other panel of, you know, would that work? Does it make sense? Given what we know has happened when other drugs have been made illegal, be it alcohol or heroin or marijuana for that matter, in terms of the actual impacts on consumption, I think that's a whole open question. If you're not going to do that, and at least by default we have not done that or come even close to doing that, if you're not going to do that, then what the hell do you do? And I would argue, you know, you assert regulatory authority.
Let me just quickly insert is that when it comes to claims, we allow claims to be regulated by the Federal Trade Commission or by the Attorney General's Consumer Protection Division. So that's the claims here, false and deceptive claim. That's what we've done up to date. The experience has not been that great with lights. When we relate hazardous substances, we turn to the Federal Hazardous Substance Agency or the Consumer Product Safety Agency to reduce hazards. I think we all accept that the current conventional tobacco product is so hazardous that walking down that road is very, very difficult, very, very hard, and finding a less hazardous cigarette is going to be, you know, quite a bit of work. We go to a drug agency because why do people smoke? They smoke because of a psychoactive drug called nicotine, and then all the reinforcing agents that are delivered along with the nicotine to enhance dependence. So in a sense, it is a natural fit. I mean, the agency should be dealing with nicotine and the related constituents, characteristics that contribute to drug dependence. And we should be looking at this as a way to lessen drug dependence and lessen use, and not be worrying about claims as much as we have to, and we're going to have to do that. Now, is the bill perfect? No. I mean, this thing is this is sausage factory at its best. I'm the first one to admit. But I like to believe in this country, and that maybe this country can do something right once in a while. We really screwed up regulating 2 other drugs, alcohol and illicit drugs. I'll be the first to admit that. But, you know, maybe if we believe and we take some risks, I think Grant said it best. He called moral courage. And that is the willingness to take risks but assume the responsibility for what you do. And I think when it comes to this bill, we have to take with what we got. We got a pretty bad civil war that came out of this one. And maybe see if we can get this agency to finally give us a federal role on curbing tobacco. I was there, I tried it at the state level, and I got my head handed to me. We need, in certain areas, we need the federal government's help, unfortunately. And I think that's true of any public health issue we face.
Just a comment. We asked the FDA to let somebody come and participate in this. We asked both Dr. Sharfstein, who's the associate director, commissioner, who is from the, trained here at BU, and also, and I forget his name, the physician who just got hired to run their tobacco shop. And not surprisingly, and I think quite legitimately, they said, we can't come and talk because, now that we're government officials, it's like the whole thing Cheryl had with lobbying. We can't come as government officials and talk until we have government policies around this stuff. And quite honestly, we don't have a clue yet. So we're going to stay away from that. But just one other sort of editorial comment, it strikes me that there's almost, I hear almost a harm reduction argument in this discussion about the FDA. We've talked about harm reduction in a lot of ways, and one argument could be said in harm reduction, we're better off having some government agency try and do it. I mean, that's a whole broader issue on whether they will screw it up, but I suspect that's analogous to some of the harm reduction discussions we've been having about products themselves. Is it better to have the agency do it, even if it's not the perfect agency at this point, than to not have something at all? Leonard.
Oh, just to comment on your point, Cheryl, about the law says that the cigarette companies can't say that it's authorized by the FDA or safer. It actually uses those words, which to me, by the way, is like the oddest part of the legislation in its entirety, that the FDA, I assume the reason why the FDA is supposed to do this is to make them safer, and then you can't say it. By the way, if there's any part of the bill that's unconstitutional, it's that one. I mean, both the advertising and this one will go away. But it's like weird to have an agency say you can't actually tell people what we've concluded about the product. But that's actually not what I wanted to talk about. I just wanted to comment based on what you had said. And what I want to ask about is sort of the moral aspect of this and how much this goes into the moral aspect of smoking. So I guess the question isn't just, because I'm not sure if what I'm hearing is that some people think it would be bad to have a safer cigarette, that it might increase the number of smokers. And the question is, would it be bad to have a cigarette if it increased the number of smokers and brought down overall mortality? So is the problem smoking, or is the problem dying from smoking? So if we can get 50,000 people a year to die from smoking, right, that would be pretty big. That would be a pretty big number. It's like cars. It's like automobile accidents, essentially. Would we be fine with that then? Or is there still a problem?
Well, you know, the science that we created in Massachusetts and California didn't include, in quotes, safer cigarettes. And we achieved a 50% decline. In California, it's probably even larger by applying changes in social acceptability, public education strategies, price. And that decline is not stopping. That decline is continuing. And we never embraced harm reduction. If you bring in safer products and who embraces it, I think, again, I get back to the population. If it's children, if it's ex-smokers, if it's someone who was going to quit but now no longer worries about clean indoor air, then that could cause harm. But we don't know the answer to that. And I think the cautionary principle in public health says, well, we should probably get some answers, not exhaustive answers, but some answers until we embark on that road. The smokeless tobacco experience in the United States was one not of adult smokers switching to smokeless tobacco, which if they did totally would be tremendously safe, but of youth taking it up and then many of them going on to smoking. Now that was a negative experience, in my opinion, with a safer product. Does the e-cigarette result in the same? I don't know, but I'm not ready. The other bigger question is, I mean, is just nicotine. How much nicotine addiction are we willing to accept as a society? Are we willing to put nicotine in right guard, the water supply? Are we willing to let people put it in other products? And that's more of a theological and moral and ethical question, and that's way beyond my scope. But, how do we look at nicotine in our society? I think there is a safer cigarette, and that's one that's not used. I think it's terribly safe. But you raise good questions. I don't think virtually anyone in this room has ever considered underarm nicotine, but it's an interesting, interesting concept. Patrick?
Yeah, thank you for your question. I mean, it raises a very important issue, and one which rarely gets discussed, particularly when there are people or groups who don't agree completely on these issues in the same room together. I mean, a good example, I think, of how this comes to the fore is the very recent one, the one you may have read about in New York City, where I believe it was the Parks Commissioner, this notion that they might ban smoking in parks, and when asked why, his response was that this wasn't about secondhand smoke and the ill health effects, but rather because children should not see people smoking. And obviously this is why, I mean, this is all part of this denormalization campaign. And it gets to the issue, as your question raised, of whether we are battling ill health or whether we are battling smoking. It can be very frustrating because it appears that for many people who are
100% committed to improving public health, I don't know if it's a fear or a frustration that so long as the act of smoking a cigarette is there in public, that somehow the war is not won yet. I mean, that's not my view, so I don't know if that's an intellectual view based on research. I haven't seen the research if it is, or it's an emotional one, or whatever. But the public health community, in concert with government, has decided in this country and in many other countries that we can have two classes of citizens, well, actually three if you include fat people, but we can have non-smokers and we can have smokers. Now, smokers are not blamed for smoking. Obviously, it's a trick that's been pulled on them by the industry, and that's why they can't quit. But they are tolerated, but they're accepted but not tolerated. And this is policy now. And I think there's two issues it raises. One is, does this or does this not help reduce smoking long term, and the public health question? And secondly, arguably more importantly, but I appreciate beyond the scope of this discussion, is what kind of a society are we making ourselves into? Because it would be very easy to substitute for smokers another group that is considered to either be or to have practices that are bad for public health or simply immoral or whatever the case may be. And I imagine the reaction might be quite different. So it's a very, very important question, but one that most of the time we're afraid to address.
Michael?
I wanted to address Leonard's question, and I think Dr. Brooks was alluding to the same type of analysis, which is, do we have to look at this solely from an individual level or a population level? And I think that when I became a physician, I took an oath. And one of the things that I said in the oath was to do no harm. One of the basic principles of medical practice, and I think it should relate to public health as well, is to do no harm. And to me, that means that you have to look at the overall public health impacts of any policy. And if reducing the carcinogens or making a safer cigarette results in the saving of lives, but also results in more people smoking, I think you have to look at the costs and benefits, and I think you have to have a weighing of the costs and benefits, and I think you need to do what's best in the overall population's interests. And this is why I have to reject the argument that electronic cigarettes should be taken off the market while we do these studies, because to me, that's doing harm. As a physician, if a patient came to me and said, doc, I quit smoking, I'm an ex-smoker now, but I'm smoking these electronic cigarettes, I would never tell that patient, well, you better go back to regular smoking because we're really not sure. Let's do these tests. You go back to smoking, and when we're done with all the testing, we'll tell you whether you should have gone back to the e-cigarette or not. I mean, that's doing harm. To me, that's malpractice. If I told a patient that would be medical malpractice, because I know that they're much better off smoking the e-cigarette. No one has even suggested what the possible harms from the e-cigarette are. So I don't think we can do harm. I think that is against the basic principles of public health. So I think we have to look at the overall population effects.
Yeah, just to add, Mike, if you prescribe that cigarette to an individual, I wouldn't have a problem, given the weight of your knowledge, your training, your expertise. But when you're not prescribing that, the relationship then becomes much different. In society, as a physician, when you prescribe a medication, you are trained, you become the interface to make certain clinical judgments and to draw decisions, what's in the best interest of that patient. But we're not in that situation. You're not only making a decision for a patient but for a much larger population where there's just not only e-cigarette, but there are hundreds of other cigarettes, mostly called light cigarettes, where the deception is broad, the knowledge is not there, and all I'm arguing is so long as it's over the counter, then we need a system to weigh the risks and weigh the evidence on a societal basis, not an individual basis. As an individual physician, I will respect your right to make prescriptions and decisions based on your science and your knowledge, but
this is not the situation, unfortunately.
I guess to bring it a little bit bigger than cigarettes for a minute, you all have had the opportunity to go and pass this, work on passing this bill, and go up against these huge corporations. And public health kind of seems to be that Jiminy Cricket, that voice of conscience out there, that the morals, kind of we represent the morals. And we don't necessarily have the funding that these huge corporations do. When they go out there, they're going out there and they're fighting for their survival. They're fighting for profits. And we're fighting for everyone's health. And so whether it's cigarettes, whether it's gun control, whether it's healthcare, whatever it might be, going up against these kind of behemoth corporations, it's daunting, and they have almost unlimited resources at their hands. And so I guess from your experiences in this, if you were to do it again, how would you redesign the campaign? Would you do something differently? But also kind of, this is kind of the classic David versus Goliath. And I guess from your experiences, where do you see as kind of Goliath's soft spot?
I'll just say a quick one. That's why you're in public health, and you're going to love it.
Well, I mean, here's the point. This is really fascinating. The news that I have to break to you today is very sad news. The entire paradigm that you brought to us with a great question has been destroyed. That paradigm is simply not true. The whole premise of your question has been undermined, because it's not public health going against the big corporations. What happened in this legislation is public health teamed up with the biggest killer corporation in history, whose products are killing more people than any other company in history. This was a Philip Morris / public health led piece of legislation. So the entire premise has been destroyed and undermined by the process that led to this legislation. As Patrick recounts, the bill was a result of a negotiation between one of the public health groups and Philip Morris. And so that's what led to this bill. So it wasn't public health fighting big tobacco. It was public health joining up with, allying with big tobacco and saying, together, let's pass this legislation. And so it's not a question of this bill versus, it's not a question of the public's health versus big tobacco profits. It's actually a question of, I would argue, in the reverse. Everything that this bill does, it does to protect Philip Morris's profits. So I would argue that this is an example of public health taking an action which is preserving and protecting tobacco industry products at the expense of public health protection.
If you're going into a fight in the playground, you want to try and get the biggest kid in the playground, the toughest kid in the playground on your side. And that's exactly what the public health establishment did. So a deal with the devil has been made. Now, some of us think the public health establishment got completely burned. They didn't have a clue what they were doing and are going to regret it in unbelievable ways. Now, others obviously disagree. They think it was a good deal. But I think what is incontestable is that it was a deal with the devil. So that is how you do it. You make political compromises. And it takes, as it did in this case, it takes years. It takes under the radar. It takes, behind the scenes. It takes everyone refusing to admit that any of this ever happened, et cetera, et cetera. So you adopt the tactics, quote unquote, of the other side. And sometimes you can win, politically, legislatively, if not necessarily in terms of public health.
I would just, as I said in my brief remarks, and I think we have to keep in the forefront of our thinking, unfortunately, we are in a country where, for a variety of reasons, we have decided to give large and powerful employers and large and powerful business far too much control over our political process than they should have. I'm sure I'm not the only person in this room who thinks that corporate lobbying ought to be massively reined in because of the way it distorts the system. I would remind everyone in the room, though, that the lead sponsors of this bill were two, if not the most liberal member of Congress in the Senate, certainly darn close to the most liberal member of the House and Senate. And they believed they got the very best possible bill they could get within the context of the political realities. Let me tell you one thing. An executive from RJR sits on the board of the Congressional Black Caucus. If any of you have read Joseph Califano's books on the history of the Johnson years, you'll know that when it came time to push through the Voting Rights Act, what got it through is a deal made with the southern states, and the deal was put together by a tobacco company to pass the Voting Rights Act. That is not lost on black politicians. So it is a very politically complex situation when no one was willing to buy advertising in GLBT magazines. Who was there? Philip Morris and RJR. They have been stealth in the extent to which they have gotten their clutches onto all aspects of our society. If you go to Kennedy Center, you see Altria's name. If you see a play, the odds are you are going to be given a candy to put in your mouth because they'll be smoking in every Tennessee Williams play from beginning to end, even when in the original script there wasn't any smoking. So in a sense, we have no idea. If you go to the Museum of Modern Art, the first thing you see when you walk into the new wing is a giant NASCAR car that has Marlboro's name along the side, and they're one of the primary donors to MoMA, to the Museum of Modern Art. So really, these companies are everywhere. They have, if you look at their internal documents, they have planned and executed, and they did it with women's groups very successfully, a plan to co-opt as many elements of society as they could possibly co-opt. And it should come as no surprise that they have a heck of a lot of power that they don't deserve in Congress. And I would simply say, consider the alternative, which is to simply do nothing.
Let me just say, I mean, we have all these opinions on the bill, and I think their opinion. I think in public health, what we have is we have science, we have the skills, we have the really respect for, what's morally right, social justice, and we outwork these guys. We work harder, we work longer, we're smarter than they are. And when push comes to shove and the day's over, our smoking rates now are down 50%. That was no accident, and that was a handful of people who are committed to public health to make change. I'm not afraid of change. I'm not afraid of exercising moral courage. I'm not afraid of going against Philip Morris. And I would say to anybody in this room, that's what makes public health great. That's what makes it really worth doing it, rather than working for Philip Morris or some of your friends working for some big companies. And you can make America change, each and every one of you in the room. Just take your science, be a knowledge breaker, get to that table, and stick to what social responsibility is all about. That's what makes us different.
Okay, brief question. We'll end on that.
Yeah, I'd like to just remind people that public health has its skeletons in the closet, like forced sterilizations, Tuskegee experiments, testing of AIDS drugs on foster children throughout the country in the 90s. Sir Michael Marmot said that autonomy, control, empowerment turn out to be crucial influences on health and disease. He's of the World Health Organization Commission on Social Determinants of Health. It seems to me nowhere in this discussion have we talked about people who smoke as if they have any free agency whatsoever. They're simply victims of predatory tobacco companies who need rescuing by public health men and women in white armor. My question to you is, and this is anybody on the panel, is this act of denormalizing smoking, dehumanizing smokers? Thank you.
I'd like to start because one of the first bits of literature that came out of Legacy's Truth Campaign soon after I became the CEO was "We Love Smokers." My view is that the social, class, and economic divide between smokers in the United States of America now, today, has never been broader than it is. And the entire process of denormalizing smokers is really a process of denormalizing low-income, poor people who are spending a big chunk of their annual income buying cigarettes. So that said, denormalizing smoking lowers smoking rates. And to me, the key question is, by any means necessary. And I would say that speaking for our foundation, by any means necessary is not in our game plan, because we do understand smoking addiction for what it is. It's an addiction. It's a very powerful addiction, I can tell you from personal and family experience. So to turn it around and point the finger at the smoker as if they alone are the problem, this is not to say that personal autonomy and personal strength and personal commitment can't help them, because the vast majority of smokers do not want to smoke, and 40% try each year to quit. 70% say they want to smoke, do not want to smoke. So I think the bottom line here is that, you know, some states have pursued, especially early on, California, I have great respect for them, they pursued a massive campaign of denormalization. They have in fact lowered smoking rates lower than any other state outside of the state of Utah, but they also issued a report, which I used when I taught public health at Columbia, and this is many years ago, and they don't have it anymore, and that report said, providing cessation services is an unnecessary distraction from population strategies to reduce smoking. And what I did is I replaced it with AIDS. Providing AIDS services is an unnecessary distraction from public health efforts to reduce HIV infection. And it would be completely unacceptable in the context of HIV, but it was the dogma of an entire state in the context of tobacco. So I mean, that's ridiculous. So I think you have a point. There's no question about that. So I'm sure others want to say something.
Michael, why don't we give you the last comment then?
I think that Stephen's making a really important point, and I think that we in tobacco control and public health need to understand the distinction between trying to denormalize smoking and trying to denormalize the smoker. And I think there has been recently a loss of that distinction in tobacco control. For example, a number of public health groups are supporting laws not to get smoke out of workplaces, but to get smokers out of the workplace. In other words, companies are basically saying, we will not hire anyone who smokes. And the biggest example of this that I think people in public health...
Hiring smokers.
Or they're firing existing smokers. The biggest example of this that people in public health need to recognize is the World Health, our World Health Organization. If you are a smoker, you cannot work for the World Health Organization. And to me, that's crossing the line between trying to decrease smoking and look at it as a public health issue, and basically going after and attacking smokers and trying to punish smokers and making their lives miserable and creating a stigma against smoking. So the interesting thing is that President Obama, when he finishes his 2 terms, will...
Just 2?
will, if he decides that he wants to go and put serve the world by working for the World Health Organization, he will basically be told, sorry, we're not interested in you.
Won't he be using electronic cigarettes by then, Michael? Well, fascinating. We started off with a focus on we planned this with a focus on a very important issue, but rather circumscribed issue around the FDA regulation and what that meant. And I think we've had a wonderful exchange around issues related to those specific questions. But I am really happy that this has broadened into questions of our politics, the legislative process, how we function as a society, and perhaps most importantly by public health. Is it David or Goliath? Have we all been co-opted? What's really going on here? And I perhaps take the image of Jiminy Cricket in public health. I hadn't quite thought about that, but I guess it kind of works. But I'm particularly impressed that a member of what I consider the younger generation knows who the heck that is. So maybe we do have a common ground. I want to thank our speaker and our panelists for, I think, doing a wonderful job of making their points and disagreeing in an agreeable fashion. All right? I hope they've given you lots to think about. They certainly have for me. And this will be a remarkable unfolding. And perhaps we can come back for the 20th anniversary of the Bicknell Lectureship and talk about FDA regulation of tobacco. Has it worked? Where are we? What are the next set of problems? All right? Well, thank you all, and thank you for coming.